just very quickly want to tell you about our new to general practice programme that's launching in April. So bookings are open for that now. So eligibility for this programme is anybody in a registered clinical role. So our nurses, our GPs, our AHPs, our pharmacists, anyone in one of those registered clinical roles. It's a year-long programme, so encompasses quarterly training sessions, and your practice will be paid backfill for you to attend those half-day training sessions, lunch included, covering topics like leadership, local system structure, quality improvement, kind of more generic rather than clinical training. And as I say, that's a quarterly thing. And then everybody that signs up to the programme will be allocated a mentor external to your practice to support your practice in supporting you in early career or early career in general practice, because actually what we know is that lots of people will come from secondary care role or from somewhere different but will be new to general practice. So this is for them. So anybody that's new to general practice in one of those clinical roles. Now, Craig, I don't know if you can drop your share. I'll just show everybody where to find it on the website. Let me open it up. So yeah, so on our website, you'll see on the homepage, we've got professional development, and then down the bottom, the new to general practice programme. So this page here on the website gives you all the information that you need on the programme and that your practice might need. So there's lots of information there about the mentorship, the supervision, the funding. And then if you want to apply for it, the apply now button is there. There is a downloadable information pack on it. So if it's something you wanted to download and have a read or send to your practice manager. And we've got all of the dates for the full education programme across the year. So they're all confirmed and booked across the year now. And funding arrangements, because that's important as well to understand the funding too. So that's where you'll find it on the website. I'll put the link to that page in the chat as well. If anybody has got any questions about the programme at all, then feel free to contact me. I'll put my direct email in the chat too.
That's perfect. Thanks, Claire. It's really important that we kind of spread the word, isn't it, on that, and make sure that people do it, because obviously if we don't get the uptake, we won't get funding to do any further training in that and supporting new people to general practice. So it's really important.
Absolutely. And we know that people, the key point when people leave is within those first 2 years.
Yeah.
So actually, if we're giving them even more support in that first year, we understand that actually within practice it's so busy with all the clinical work, sometimes it's really difficult to provide some of that other kind of support. So if we can help do that and actually get people working together, getting all the different professions working together, I mean, it's a brilliant programme. We've had lots of interest already, we've had lots of applicants already, so yeah, I would encourage people to apply as soon as possible, ready for our April start.
Perfect. Thank you, Claire. That's amazing. Right, so I'm going to quickly hand you over quite quickly now to Sophia, who you can see is already there and waiting, which is fab. And she'll introduce herself, and she's from Lantum. She's going to talk about some locum opportunities. So I'll hand it over to you.
Brilliant. Thank you very much. Just bear with me while I share my screen quickly. Hopefully you can all see that okay. Perfect. Brilliant. Well, hi everyone. I hope you are all having a nice day so far, and I really appreciate you slotting me in today as well. I appreciate there's a few speakers coming after me, so I will try and keep this as succinct as possible. I do tend to waffle, but I will try and be quick. And also just a thank you to Claire for inviting me, and Mel and Craig as well for helping facilitate it all. It's really appreciated. So my name's Sophia, as you can all see, and I'm a client success manager here at Lantum. But actually, for most of my career prior to that, I worked in the NHS, admittedly not in clinical roles. I can't take as much credit as all of you can with regards to that, but it's really nice now to be working at Lantum as well. I still get to work really closely with NHS colleagues, especially throughout primary care. So I will go through a little bit of detail about what I'll be covering today, but I'm also conscious that maybe some of you have never heard of Lantum. So just a really quick summary of what Lantum is. So essentially Lantum is a digital tool and an app that essentially was created over 12 years ago now, really with the aim of trying to modernise how healthcare organisations like GP practices and professionals like yourselves basically connect with each other. And the whole aim really is to support general practice with their staffing. So we are here to support practices when they have staffing gaps, but we are not here, and we are not an agency at all. So we're not here to replace substantive staff or encourage everyone all to be locums. That is quite the opposite. We are literally here to basically help connect people where practices have shortcomings due to leave or sickness. So, you all know what it's like. Things can crop up at any point. So it's really just there to help make those connections when practices need it. So why am I here today? So essentially, I'm here today to talk a little bit about some additional flexible working opportunities or locum opportunities in Northamptonshire. As many of you will know, GPs have historically and for a very, very long time, been associated with locuming. It's quite a common thing for GPs to locum. It's something they're normally quite comfortable with. And even throughout secondary care, working bank shifts and additional shifts is very common for all different staff types. But actually in primary care, while there is other opportunities, where Lantum comes in is that we help across the region, so more widely allow people to connect with different practices across the region.
Sophia, have you got slides? Because we're still on the first slide. I didn't know if you did or not.
Yeah, I do. Yeah. This is just I'll move on to those in
okay. Thank you.
No worries. Thank you for flagging though, because I've been there before and it's a nightmare. So thank you, Mel. But yeah, essentially, so for the past few years, Northamptonshire and Lantum have been partnered. And we've been building what we call a local flexible pool of staff. So I'll go through this in more detail on the next few slides. But essentially, the whole aim is that we're connecting local clinicians with local practices. And the reason we're here today, like I say, is because we're hearing more and more from practices and actually nurses as well, that they're looking for more locum opportunities in the region. So if I just move to my next slide, I've already gone through this as a bit of an overview, so I won't bore you too much with this on this slide. But essentially, Lantum has been around for the last 12, 13 years now, and we've got really strong relationships. I'm really proud of our connections across the UK with lots of different practices and ICBs as well. So we work with around 50% of practices, and traditionally we have mostly, like I said in the last slide, focused on working with GPs, but we're seeing more and more that demand and that crucial support that practices need from their nursing colleagues as well. So I'll go through in a little bit more detail exactly how to join and what that looks like. But essentially, I wanted to give a bit of an update and a summary of what exactly Lantum is and why this need. So the way essentially that Lantum will work is, let's say you're a practice manager and you have a gap in 2 weeks' time because your lead practice nurse, let's say, is off sick, and you know that maybe one of your GPs is also off and you're just generally going to be quite short-staffed. That practice manager can literally go onto their Lantum profile, and the majority of practices within Northamptonshire have accounts. They can just go on, they'll post out the session that they want to fill, and they'll say, I would like a practice nurse for, 8 hours on this particular day. And then when local clinicians and nurses, for example, they'll have the app downloaded if they're all set up and ready to go. And all they have to do then is apply into that session that practice has posted. The practice manager will review it, and then they will go from there and they'll be able to complete the session. Once you've completed a session, it's as simple as just basically submitting your timesheet afterwards, which I'm sure a lot of you will be familiar with, and then you'll get paid via Lantum for that shift. So it's really easy to use, and actually this graph on this slide here is really just to show, don't worry about the details too much, but it's really just to show that in Northamptonshire, we just don't yet have enough practice nurses and ANPs and other nurse types as well registered and onboarded onto Lantum. So what we're finding month on month is that we have a group of practices that are posting and need that support, but there aren't quite enough nurses yet to fill that demand. And actually, we're want to make sure that you're all aware of this opportunity, so that if you are interested, and it's completely optional, this is not something you have to do, but if that is something that's of interest to you, that you're able to sort of know how to sign up, know where to find us, and make those connections as well. So why use Lantum? So one of the key benefits, like I mentioned earlier, is that over 85% of practices within Northamptonshire are signed up and have access to Lantum. So a lot of them are using it actually for posting out sessions where they need that extra support. But really, Lantum's meant to be something that's just really easy, not give you a headache for using it, and give you that flexibility and transparency where you have it. So there's a couple of key features that I think are quite popular with clinicians. So one of them is we have a feature called Rocket Pay, which essentially means that if you opt in, there is a small fee and it's completely optional. Any session that you do, you could get potentially paid the next working day. We tend to find that's very popular around Christmas and birthdays and things like this, where people want that extra income. But there's also really great transparency. So when you apply for a session, you know well in advance how much that practice manager wants to is sort of setting that rate for the hour. So you have full view of that, and you have the opportunity to negotiate not only the hourly rate, but also the hours as well with the practice manager. So you can find the best solution for both of you. But I think what's really nice, and we find lots of other regions where we are launching or have launched nurses on Lantum as well, is that we really do find that people form relationships with practices they wouldn't have usually. You know, if you get along well with the practice and vice versa, we tend to see people working with them more and more when and as they want as well. And like I say, once you download the app, and I'll go through in more detail how to do this, there's a really handy app that you can download where you'll see all of the sessions that you can apply into and details of what you have already worked, etc. as well. So one area that we have worked with quite closely is Birmingham and Solihull. So they've launched a really successful nurse pool. We now have over 70 practice nurses and AMPs in their flexible pool doing a lot of regular shifts. And we have a quote here from Dahaba, who very kindly shared this with us for this presentation, just to say, you know, some of the things that they really liked about working with Lantum to do with finding it easy, the invoicing process being really quick, and just really recommending it. That being said, from speaking to lots of other nurses at Best Practice and some other events as well, one of the key things and pieces of feedback we hear is that it can be quite intimidating to all of a sudden think about locum work, especially if you're used to being substantively employed, because it's a different way of sort of getting paid in the sense that you're technically self-employed for any locum work you do. Although we're not a tax advisor or financial advisor or anything like that, we do have a blog that I've linked, and hopefully when we share the presentation, you'll be able to sort of click into that. But it just gives a little bit more detail on what to expect and what that looks like. Obviously, lots of GPs do it and they find it quite straightforward, but I am aware that is sometimes a consideration for people, so I'll send that round. So just very lastly from me, how do you join if you're interested? So I will pop a link in the chat as well, but essentially all you need to do is there's a specific link to sign up to the Northamptonshire pool. That's really important. There's a unique link, so that what that means is that if you join, you are part of that unique flexible local pool. And once you've created your account, you're just prompted to upload 3 core documents, which are your passport, your CV, and your DBS. There are options to upload other documents as well, and we really encourage that. You know, if you've got any like vaccination certificates and safeguarding courses, like anything you've done, basically, the more the merrier, because it strengthens your profile. But those three documents that I mentioned first are the core ones. They basically get reviewed by a clinical governance team who are in-house, and once they are all checked within 48 hours maximum, then you will be ready to work. And then all you do is once you've done that, you'll have the app. You can literally go on, put in your postcode where you live or wherever you want to set it as, and then you can set like a miles radius that you're willing to travel, and then it will show you all the work available within that sort of geographical radius. And then all you need to do is click apply or chat with a practice manager to negotiate, and you're good to go. And then from there, you complete the session. If you've opted into that Rocket Pay feature, you can get paid the next working day. If you haven't, that's absolutely fine. You'll just get paid in the normal sort of payment cycle that the practice runs, which is normally 30 days or so. And then that's how you'll get paid as well. So on the right hand side here, I've put a QR code. I will share this link as well in the chat, but I put my details there as well. So any issues with signing up, if you are interested, you can just let me know. Or if you're not interested in signing up or have any questions or hesitations, I am always more than happy to hear from people. It's really nice to chat to people from the region and get to know people and answer any questions you have. So yeah, never be a stranger. My details are there if needed as well. So yeah, that's me done. Thank you so much for listening and for your patience. I appreciate not everyone on the call is necessarily from the nursing like staff type, so apologies for those of you that don't fall into that quite yet, but I hope it's been helpful for those of you that are, and yeah, nice to meet you all and hopefully speak soon.
Thanks, Sophia. I just got a quick question, just to sneak in quickly. You're saying actually about different staff groups. So obviously we've got other staff who work as advanced clinical practitioners. So I'm guessing they would still be able to sign up with Lantum and cover those advanced ACP shifts.
Yeah, that's no problem at all. Yeah.
Yeah, brilliant. And I've noticed a question in the chat saying, is there a set payment or is it down to the GP practice?
That's a really good question. Thank you. So yeah, one of the great things for practices is they have the complete autonomy to set their rates. So typically they're standard. You don't normally see anything too wacky or too low or too high because they wouldn't attract anyone. So it is up to the practice manager what they set. But what I always say to people is the whole point of this is to like empower clinicians and the practices to, you know, come to like a rate or hours or whatever it is that works for you both. So if you see a shift that you really want to do, but you're like, do you know what, I could do with a few extra pounds per hour for that session, it's worth just messaging them and asking. There's no harm in it. They can only say no. So yeah. I can also see some other comments as well. So oh, apologies about the QR code. Let me send an updated one round with the presentation, and I'll pop the right link in the chat as well. For AMPs to work remotely with laptop and phone. So it totally depends. Some practices will set that and they will send that out, put that on the shift. So when you apply in, you'll have more details. Typically we found they're in person, but if they are remote, they will say. Philippa.
I was just going to ask something, and I've just noticed it's in the chat as well. There's quite a few pharmacists on the call. Do you do shifts for pharmacists as well?
So the answer is technically we have the functionality to allow pharmacists to work through the platform. What we haven't explored yet, so it's not a no, but it's not a yes either. What we haven't explored yet is we haven't had a load of practices come to us at the moment that have said, you know, we definitely need pharmacists. But Claire and I have actually been working on a survey that we want to send out to practice managers, which we're kind of going to ask practices like, what's your current need for staffing? Do you find you need nurses? So we could always include pharmacists into that if that would be helpful. Because if they say yes, then we could look at launching that.
Yeah, I think there's a lot of remote pharmacy companies that offer online pharmacy reviews. So I think you've kind of got competition, but I think the advantage of Lantum is you're offering local expertise, which I think is really powerful. So happy to pick that up with you and Claire outside of here.
That'd be great. Thank you. Brilliant.
That's great. Thank you, Sophia.
No
That's fabulous. And you're going to share the slides, aren't you? And we'll make sure we get those out. Yeah, lovely. Thank you very much. That's fab. Thank you for coming along. If we get any more questions, we'll head them your way.
Brilliant. Thank you.
Lovely. Right, and just in time, on cue, there is Philippa. So our next session, we are slightly overran just by about 5-6 minutes, but hopefully we'll be able to catch up. So our next session is chronic kidney disease management, and we've got Dr. Georgina, I'll get my words out, Aldous, who is a consultant nephrologist at NGH, and we've got our lovely Philippa Jones, which is our principal clinical pharmacist. So it's a slightly longer session. We normally do sort of hour blocks. This is sort of 2 hours, but I'm sure they planned it so it's, well, I don't know if there'll be a break, but I'm sure it'll be really interactive and very interesting. So I'm going to hand you over.
Now, can I check before you go? Do you still need us to finish by 3:15? Because I'm just so that we can try and pace accordingly.
I can message, that's fine, and I'll say if we could just move respect by another sort of 5-10 minutes.
Yeah, that's fine. We'll keep an eye on the time and try and catch it back up, and we'll try if Georgina, are you able to pop? I don't know if you've popped your camera on already. I've started sharing the slides, so I can no longer see anybody.
Do you want me to look after the chat, Philippa,
that's
or
exactly
do you want
what I was about to ask you? Yeah. Georgina and I are both very, very happy. We discussed this yesterday. We're very happy for people to chip in and interrupt us with questions. Obviously, we can't see you, so Mel, just stop us and interrupt us. We're both chatty people, as you will soon realise, and we are very happy for you to interrupt us, and we want you to be engaged in the session, and often if questions come up at the time, we'd rather deal with them while we're talking about that topic. So please stay present if you can, and do send those questions as you come, because that discussion is obviously really, really valuable, and we've tried to make it sort of an appropriate level, but I know there's a real mix of people on the call as well. So if we're saying something that either you don't understand or something that you want more detail on, we will respond to that. Just ask us in the chat, and Mel, if you just interrupt us, that'd be grand.
Okay.
Thank you. So can you see my slides before we go any further? Don't want to get too carried away. Fabulous.
Can you hear me?
Yes.
Yes.
Wonderful.
Thanks, Georgina. So as Mel said, I am a pharmacist by background, and some of you may have been to the screening session we did in the PLT back in the autumn. There was lots of demand for some CKD management session, and so I thought, who better to join me than Georgina? And my background, I was a renal pharmacist with Georgina for about 10 years previously, so I have got some experience in CKD. But Georgina, did you want to introduce yourself as well?
I think most of you will have met me or seen me at PLT before. I've been a consultant nephrologist at Northampton for 9 years now, and I do clinics at Northampton General and at Daventry. Hopefully you will all find the nephrology service at Northampton General accessible. We try and answer any queries quickly, but if you do have any questions, please send them in.
Thank you. So there we go. A slide moved on. I'm just making sure we've got the basics right before we go too far into it. So you should now have the agenda on your screen, and I'm assuming someone will shout at me if you don't. So this is really what we're aiming to cover with you today, what CKD is and how to classify it. We're going to not spend too much time on that because obviously we did cover that in the screening session previously, and similarly with the estimating renal function. And setting the scene a little bit with some of those financial and clinical implications. We're going to look at some local data. So I imagine if you're anything like me, you'll suddenly be squinting at your screens and trying to find your own PCN and seeing how you're doing compared to the rest of the the ICB. And I'll also share where that data's come from so that you can look at that at practice level or PCN level and see how you're doing as well. We're then going to spend the bulk of the session talking about the management of CKD patients. So we'll do a bit on the monitoring of CKD patients, and then we're going to go into the management. So we'll go through all the management options, go through the licenses, the meds, some of the frequently asked questions, and we'll talk about the referral criteria to secondary care. But as Georgina's already said, and I can absolutely attest to that, the nephrologists that we have locally are such a friendly bunch. They are so approachable, and they really want to support you to have better CKD care for your patients. So if you are doing stuff and you're not sure, do reach out to them and ask. They're there to support you, and they are fabulous at doing so. And then we've got some case study discussions around sort of where CKD care has perhaps not gone as well as it could, and how could that be done differently. That's not to obviously where we found those case studies will remain completely anonymous, and it's not to say, oh, this person did it wrong. It's because they're things that we see time and time again, and that are really common themes. So we've tried to pull out things where we know that perhaps things are right and somebody's done something wrong. It's about learning and trying to make sure that we're getting it better next time. And you may look at those case studies and may go, oh gosh, yeah, I probably would have done what they did, but actually now I know I do something slightly different and bits as well. So
yeah, and guidance keeps changing, so it's hard to keep up. That's the other thing.
Absolutely, yeah. So fully recognise that, because some of the things that perhaps weren't done as we might expect previously are things that might have been appropriate at the time of the guidance when that happened, but we've got better, newer guidance now that will change that as well. So absolutely. Yeah. So hand over to you, Georgina.
Good. So some of you will have seen this before, but what is chronic kidney disease? So a patient is said to have chronic kidney disease if they've got abnormality of kidney function, so a reduced EGFR or GFR, or if there's an abnormality of structure that's been present for 3 months. For more than 3 months. And in addition to that, we should also say any abnormal genetic test results. For example, if someone's got a family history of chronic kidney disease, of adult polycystic kidney disease, and they have a blood test, genetic blood test, confirming that they have the disease, even if they've got normal kidney function and no cysts, you would treat them as if they had CKD as well. So I think that's fairly self-explanatory, but if there's any questions on that, please ask. So as you can see on this graph, as renal function deteriorates, then the risk of complications goes up. Though in addition to that, I think this doesn't really show on this model that as the GFR deteriorates, in addition to having an increased risk of complications, actually patients with comorbidities have an increased risk of CKD. We'll all have seen patients with advanced diabetes or advanced heart failure where they've got multi-system effects from that, and it's very much a two-way street. But as patients start to get to CKD stage 3B, CKD 4 and 5, they're going to get more anemic, they're going to have more problems with hyperkalemia, they've got more problems with fluid overload. And those patients that have got significant proteinuria tend to get their symptoms and complications earlier than those that haven't. In terms of the cost of chronic kidney disease, it's immense. We all know that a small amount of money goes into general practice and it does into secondary care. But actually, if you look at the tertiary care, the renal replacement therapy, the dialysis, the transplantation, the dialysis transport, that is what is taking most of the money. And that is a very small percentage of our patients. But I say to my colleagues, if you can just delay one person's dialysis by just 6 months, you will have saved, you know, £25,000–30,000. And if you can delay people from reaching end-stage renal failure at all, then the personal costs to them in terms of their experience, but also the financial costs are immense. And on here, we haven't got the cost of nursing homes and extra care. We haven't got the cost of them having given up their jobs in order because they're too unwell to work. So if we can intervene at a much earlier stage, so the patients that this guidance is aimed at is really those who've got CKD stage 2 and 3A and 3B, who haven't necessarily hit the point where they'd require referral to the nephrology service. But if we could intervene there and delay the progress of their disease or prevent their disease, it's going to have immense savings to the country as a whole. So this graph you will have all seen, and you can see it starts, it's looking at classification of kidney function according to both GFR and proteinuria. And in those patients who've got kidney function where EGFR is more than 60 and they have no proteinuria, then they're said to have no chronic kidney disease, unless there is a structural abnormality. So if they've got obstructive uropathy, if they've got microscopic hematuria, if they've got cysts in their kidneys with a history of polycystic kidney disease or something like that, then actually they would be CKD stage 1 or 2 with an A1. But their risk of having complications from their chronic kidney disease is very low. They're less likely to have an increased risk of heart disease, strokes, and such like. So that's why that's green. As you go up, you can see that it changes to yellow, orange and red as the risks of complications go up and the risk of progression goes up. And that's fairly self-explanatory. If anyone's got any questions about these slides, do perk up. Okay, so the next thing was about albuminuria and urine albumin to creatinine ratio, and one of the questions we're always asked is, oh, why can't we just do a dipstick? And there's two reasons. One is that the urine dipsticks only look at concentration. So if you've got a patient who's got a very dilute urine because they've been drinking sort of 5 litres of fluid a day, or someone who's got a very concentrated urine because they're dehydrated, then the urine dipstick is not a accurate reflection of their actual proteinuria. So that'd be the first thing. And actually the urine dipsticks that we use commonly to check for urinary tract infections are not sensitive enough. They're not going to check to pick up microalbuminuria, and we know that microalbuminuria has a very high correlation with risk of complications of chronic heart disease, as well as progression of chronic kidney disease. So it's important that we identify that. In terms of what does albumin to creatinine ratio, the microalbumin, or what does the protein creatinine ratio actually mean? A albumin creatinine ratio of 70 or a protein creatinine ratio of 100 is the equivalent of the old-fashioned 24-hour urine protein level of 1 gram per day. So yeah, okay. We quite often get, yeah.
Sorry, there was just a question. I feel really bad butting it in between.
No, go for it.
It just says, if the EGFR moved back above 60 after 2 GFR readings after 90 days, apart from the reading below, should they be classified as having CKD3?
It's always a really difficult one there, because actually they are at significant risk of developing chronic kidney disease. And that's where the structural thing comes in, because actually if they've had a pyelonephritis and they've got a bit of lobulation on their ultrasound, for example, or if they've got a bit of blood on their dipstick, then yes, but then you might change them back to a CKD 2 rather than 3 at that stage. But they're definitely at an increased risk. So I would certainly keep them on your CKD risk register and do an annual blood test to monitor them, an annual ACR, and treat them as an acute kidney injury. I don't actually know what the formal answer to that one is. We've had this debate with Philippa before. Are they, aren't they? And the other question is, quite often there's blood tests in between. So on your system 1, you might see 2 blood tests, but there might have been 3 at the hospital in between on ice that have actually gone back into normal range, and they were just recurrent episodes of AKI. So it's a bit pedantic as the answer, but what I would say is those people that have done that and gone back into a GFR greater than 60, I would make sure you keep them on your risk register and have at least a once a year blood test, because they're at risk of decline in future. Does that?
Yeah, I think the part of the reason we've had the conversations about it as well is obviously for those of us that are all in primary care, we know that QOF register for CKD, which will be highlighted for care, is CKD 3 and below, or above, sorry. And so if you recode them as CKD 2, you're then going to miss them. And I think the take-home message there is that they're still high risk, and actually if having them on the register means that you're more likely to monitor manually, that's probably the safer thing to do, rather than sort of putting people on and off constantly.
It's a bit like diabetes, isn't it? If someone's got a HbA1c of 54 and they've been diagnosed with diabetes and then go away and lose all that weight, have they lost that diagnosis? And I know there's a sort of huge debate about that as well, and they certainly remain at risk of developing. So I would treat it in a similar way. I would probably keep the diagnosis on there if it's safer. Good. Have you all come across the kidney failure risk equation? It was in the most recent NICE guidance, and essentially it looks at the fact that it puts in the urine protein level, the sex, the age, and the GFR in order to assess what the risk is of progression to end-stage renal failure. And one of the reasons for that is there's a huge number of sort of relatively old ladies who've got a low GFR, no proteinuria, who never get to end-stage renal failure. And there's others who are younger, whose kidney function perhaps is not as bad, who've got significant proteinuria, who are going to rush towards dialysis. And it's trying to make sure that the right people are referred to the renal team so that we can concentrate our efforts on those and not fill up our clinic slots with people with a GFR of sort of 20 that's never going to progress. In order to, the plan in the long run is to automate this and get this onto system 1 and other places so that you can see it yourselves. And additionally, the plan is to try and get the KFRE reported with the microalbumin levels when you send them to the lab. Unfortunately, computer says no for both of those things at the moment. So we are stuck with manually calculating it ourselves. But in order to do this, you've been given a QR code on this screen that you can sort of use in order to find the kidney risk factor equation. But if you just type into Google KFRE UK, you will find it on the top 2 search results. Make sure you put in the word UK, because it's different measurements and different calculations for the UK compared to the rest of the world, and you'll get inaccurate results otherwise. But essentially you'll come up with a number, 2 numbers. The first is a percentage chance of that patient reaching end-stage renal failure within the next 2 years, and the percentage of them chance of them reaching end-stage renal failure within 5 years. And if that percentage at 5 years is more than 5%, then NICE would suggest that you refer to the renal team. That doesn't mean you're not allowed to refer if they've got a percentage less than 5%. If you've got concerns about age or progression or any other concerns, then please do let us know. But essentially anyone whose percentage is more than 5 should certainly be coming our way.
There is the small caveat that if they're perhaps, 98 and in the care home and not wanting additional interventions, then obviously you don't need to refer those as well. The other thing that I would just add, because obviously we've done quite a bit of work in one of our PCNs, particularly on calculating the KFREs, is that obviously we talked about when we did the screening session back in the autumn around sort of increasing the UACRs, and we're going to look at some data around that in a minute. But if you've obviously, for majority of practices and the majority of patients, you're going to have a lot more EGFR results than you are UACR results, and really they need to be within sort of the same time frame. And I think when we've sort of escalated that question, what they've said is sort of 3 months max. Really, you don't want them any further apart than that. So if you've maybe got a EGFR from last week, but your last ACR UACR was last August, you might want to put them into the calculation, not with your current EGFR, but your EGFR in August when you did the UACR. Obviously, ideally, you'd repeat the UACR and get them up to date, but just a word of caution, if you're using the calculation, you want those two readings to be at least within 3 months of each other, but closer together, as a sort of point when you're utilising that. I think by the next one.
And if it can't take, quite a lot of patients have got a microalbumin level that's too low to calculate. If you get that, then put in a 0, 1 or 2, because I think the lower limit of ACR calculations is 2 in our lab. But certainly those are the lower risk patients anyway. And yes, in terms of referrals to us, if you have got someone who's sort of old in a nursing home, not suitable for dialysis, then the question really is there anything we're going to do in order to improve their life? So if they're very sort of anemic or fluid overloaded and you think we can give helpful advice, please let us know. But some of those patients we can also give some advice and guidance if you let us know this patient's too frail to come up, but please would you offer advice? We're very happy to do that.
That's brilliant, thank you, Georgina. So I think the next slide's me. Oh, it's not moving. There we go. Oh. So this data is from the National Chronic Kidney Disease Audit in 2017. So it's a little bit out of date, but what I would say is that there's some things on this that when we've run local data, we've seen there's some real similarities and real patterns, and things haven't necessarily changed, and some things where I think we're a lot better. So really this is showing, obviously all these patient groups should be having screening for CKD. We know that the EGFRs are fairly good in terms of those blood tests that are being done, and I think that's where diabetes is a lot better certainly than it was back in 2017. And blood pressure, you can see it's kind of greater than 90%. What we found when we looked at some of the local data is that generally if you've got people on ACE inhibitors and ARBs, for example, they tend to have those EGFRs, but if you've got somebody on just a small dose of amlodipine, they're not getting perhaps the annual blood testing quite as a robust a fashion. And then other risk factors obviously encompasses quite a lot, so there is a bit of a mix depending on what the risk factor is. The UACRs we know aren't being done as well as they could, but I do think that is now higher for diabetes than perhaps implies there. But hypertension, I think sadly we're probably still quite low, and I think that's probably quite reflective unless you're doing something particularly special. I'd like to think that since we did the screening session and we talked about UACRs quite a lot back in October, I'd like to think that those numbers perhaps have started to go up, and that perhaps you've already made more of an effort to make sure those or not more of an effort because you're a bit more aware of it now, and sort of obviously with awareness you can implement that into your practice. So I would hope to see that that's starting to go up for people as well.
There's been a lot of lobbying centrally to try and get that added on to some form of QOF, but unfortunately no amount of lobbying has persuaded anyone to do that, because it's been in the CKD guidance and the diabetes and hypertension guidance for so long, they didn't feel it was necessary.
Well, yeah, I think that's a whole other political thing. We I think let's not sidestep into QOF debates. So some of this data on the next few slides is from CVD Prevent. Now, if you're not familiar with CVD Prevent, I'd really encourage you to have a look, because it's a really good web page that's got great data. Now, I put in across our ICB, so all of you will be now like squinting at your screens trying to see how you are. Essentially your PCNs that are down the bottom, down that right hand side, so you've got I don't know if there's anyone on the call from, I'm having to squint now to see, Kettering and Southwest Rural PCN. They're doing fabulously here. So this is looking at the percentage of GP registered patients over 18 that perhaps haven't been coded for CKD, but if but the searches are implying that they should have been. So the higher that is, the more uncoded patients you've got in your patient population, essentially. The next indicator that they've got on that CVD Prevent is looking at the percentage of people over 18 with a raised UACR or PCR in the last 12 months who, sorry, I've got to get this right in my head. So obviously you would want all of your CKD patients on your CKD register to have had a UACR in the last 12 months. And you can see that nationally, the average is 44.6-ish. So nationally, like nobody's anywhere near 100% really. So on this one, higher is better. So we've got Triangle PCN, who I think were sort of second top on the last one. Triangle are obviously doing something well as good as well. They're up there above 60%. So they've got really high percentage of their CKD patients are getting that annual UACR, which is fabulous to see, and hopefully sort of, like we've been talking about, some of this training that we're doing, that hopefully everybody will start to come up on that that one as well. And certainly if you can spot yourself and you think, oh, actually we're down this bottom end on the right hand side, then really it's talking about how can you increase those UACR levels, how can you make sure that you're getting more, who's requesting those blood tests, can you get them adding on those UACRs as well there. This indicator is on the percentage of patients who've got on the CKD register who've had the blood test for the EGFR over the last 12 months. So as you can see, these are much, much higher. These are all up near 100%. So somebody's obviously doing monitoring on these patients. They're just missing the UACRs out, or the patients are not doing them. There might be lower patient compliance with urine tests, whereas I think it's human nature, and I'm sure we've all experienced where patients are generally happier to have something done to them, i.e. you taking the blood, but if they've got to provide the sample with the urine sample, they're perhaps less likely to comply. So you can see again, obviously higher is better, and so you've got red kite there right up at the top, and bits as well. So again, national average is around sort of 89%, and our system for the whole of our ICB is around 90%. So we're pretty much around sort of average compared to nationally. And then this is the last indicator from CVD Prevent on CKD. But I would say if you do go onto CVD Prevent, you will see there are indicators for different therapeutic groups. So there are, if you're doing other stuff around cardiovascular disease, you will find other indicator data sets. So you can see how you compare. So might be you do a bit of CKD, but you do a bit more of something else somewhere else. So it's worth having a look, because you'll be able to see those. So for this one, this is looking at patients on the CKD register who've got hypertension already. They've got a raised UACR, which means you have to have checked their UACR to be included in this data set, and that are then treated with your RASI therapy, so your renin-angiotensin system antagonist, so things like your ACE or your ARB. So higher is better, but there's a real caveat here that if you're not checking UACR, then you're not going to have identified a lot of your patients. So you'll have a much smaller cohort. So you potentially could look really good on this because you've got loads of people on RASI therapy, but actually you only look good because you've not identified most of them because you've not done any UACRs. So I think you kind of need to look at this in conjunction with your rates of UACRs as well to see how you're doing, and not get too excited if you look good on this unless you are also very good at UACRs, if that makes sense. So this slide, we were just looking at the frequency of monitoring. So really what we're talking about here is just the fact that obviously we've used the same sort of tabular format that Georgina introduced earlier in terms of the diagnostics and categorizing of the CKD, and the colours obviously sort of mirror that as well, that where you've got your lower risk patients, annual monitoring is absolutely fine, that's adequate, unless obviously something else has happened that gives you cause for concern, or perhaps you're doing additional monitoring due to drug changes. That's obviously goes without saying. But in terms of your no changes, everything is stable, they've just got this category of CKD, annual monitoring would be sufficient. But as you move across this, so if I've just realised I can have a laser pointer. That's very exciting. So right up here, we're really happy with these people just having annual monitoring, and similarly for those here and here. But as you kind of go across and diagonally down, you then want to be looking for kind of more 6-monthly monitoring, and then for these more severe CKD patients, so your CKD4s and A3s, where you've got, I mean, these are most likely, the majority of these patients are going to be under secondary care anyway, but you'd then be looking at sort of more 4-monthly. And I think, Georgina, you were mentioning yesterday, I know when we were looking at these slides, that actually what you sometimes see in nephrology is probably more testing than you need rather than less, seems to be the trend. So perhaps some reassurance that you don't need to do it quite as often as some people are.
I think the ones we see a lot of testing on are those that have had an AKI in hospital and they've been sort of discharged with their monthly monitoring to start with, and it's never fallen off. So unless there's something else like immunosuppression that's requiring monthly monitoring, very few of them will need it that often once they've got beyond their AKI. I suppose the other thing to say is those that are sort of orange and red on this chart are the ones who are most at risk of developing other complications such as anemia. So if you are doing the bloods every 6 months or 4 months, those patients would benefit from having a full blood count done at least once a year, would be the other thing to say, which isn't on there. And I think the other comment I had was those that have ever had AKI at any stage in the past, it's not part of CKD monitoring, but they do need an annual blood test, because you'll get someone who's had an AKI, fully recovered, and then 5, 6, 10 years down the line, they start getting progressive chronic kidney disease. And if they've not got something else to have flagged them up as being at risk, they won't be monitored, and we quite often find them quite late. So all patients that have ever had AKI should have an annual user needs once they're sort of stabilised back to their baseline.
Yeah, absolutely. Really important to keep an eye on those. And I think as well, we talked about that in context. I know I keep sort of referring back to screening because obviously we're trying to focus on the management today, but in that screening session, we went through all those high risk groups, and those previous AKIs were on that list. And if you're not sure, or you weren't in that training session, or you perhaps can't remember what all those high risk groups are that should be having that annual monitoring, they're within the NICE guidance for CKD. If you look on the NICE guidance for your high risk CKD screening populations, it gives you a bullet point list, and those AKI patients are one of those really important groups that Georgina's just been mentioning. So some general advice about patients that are getting the monitoring done. The not eating meat is in some resources, but it was interesting because both Georgina and I said we didn't necessarily tell patients this, we just used it as an explanation in terms of why their results may deviate. Certainly, I know when I used to do transplant clinic with Georgina, what we would see is the transplant patients, some would get really, really good at being vegetarian the day before their creatinine test because they didn't want to risk it looking worse, and bits as well, because patients become quite, and that's because those that EGFR, just sort of trying to remember the background of where that calculation, and remembering that is an estimation, and that creatinine is that muscle breakdown product. So if they've eaten a lot of muscle products, i.e. meat, then that can influence the result. But it's a good explanation where you perhaps have a change or a dip, is that a reminder that it is an estimation. So that's not a hard and fast rule, and certainly not something that we feel you need to sleep over, but something you might want to take into account when you're interpreting those results. Urine sample for UACRs should be the first urine of the day. It's meant to give a more accurate result. I know when we submit them on ICE, generally if it comes back raised, it asks you to repeat with an early morning sample. So I generally go with suggesting the patient does an early morning sample. And I think given that we're in primary care, a lot of the time you've got to have those samples back in the morning anyway to be able to send them off. So actually getting the patient to do it earlier in the morning perhaps helps to encourage it to happen. But certainly please don't not do it. If you've got a patient booked with you at 10 o'clock for a blood test, I would say put the UACR, get it done if the patient's able to go and provide you with a urine sample there and then. I wouldn't not do it just because it's not the first urine of the day.
No, we take the one when they turn up in clinic, to be honest. We're not pedantic about this at all. And the other thing is, if they do send it to you in the afternoon, it is fine sitting there till the following morning to be sent off. There isn't a problem with that.
Helpful, thank you. So then there's a reminder about sick day rules. I'm going to talk a little bit about these on the next slide anyway, so I'm going to skip over these for now. And then some general advice is really helpful for the CKD patients around non-steroidals. There are loads that are available over the counter. You will all be aware that you can pick up medication that contains non-steroidals from anywhere, from a garage, from Tesco's, from lots of places where they're not going to have any medical advice, so be that advice from a doctor or a nurse or a pharmacist or anybody. So real caution, particularly around things like coughs and colds remedies, where they might be not patients won't necessarily know what a non-steroidal is. They might be unfamiliar names. There might not be products that they've realised are a non-steroidal. So it's perhaps trying to encourage people to go to the community pharmacist where they can get that advice, or checking, or just avoiding those things altogether if they can, and just taking some care around those, particularly when you think about a lot of these patients are going to be on RASI therapy, which if you're combining it with the non-steroidal, you've got much higher chance of giving that patient an AKI or causing a deterioration in their renal function. So we just want to be really careful and making sure that we've educated our patients about that. Aspirin and cardiovascular history. So historically, going back certainly when I first started working in renal, sort of 10-15 years ago, or maybe longer, we used to have primary prevention of aspirin, and I think you still get the odd hangover patient that's still on a bit of aspirin for primary prevention. But as I'm sure most of you are aware now, that the guidance changed quite a few years back now, and unless the patient's got a cardiovascular history, it should only be prescribed for secondary prevention. So that's for all diabetics, that's for all your CKD patients. So if they are still on aspirin and don't have that cardiovascular history or no other indication, you can safely stop that. And then a reminder that you review all the other medicines. So think about what is being cleared renally. If it's being cleared or metabolized by the kidneys, you may need to have dose adjustments. That might be dosing intervals. So it might be that something needs to drop from twice a day down to once a day, or it might be the dose itself needs to be capped slightly lower. You might need additional monitoring on side effects, or you might need dose reductions on the dose itself that you're giving. So always have a think about what else are they on. Are they at increased risk of toxicity, or is this still the right drug for them? You know, is there a condition medicine interaction as well, thinking about that side of things. And I think most practices now have pharmacists that should be able to sort of advise on those if it's something you're not comfortable with, or perhaps not sure about. It's a good use of your sort of pharmacists within your practice. So this, so I said I was going to come on to sick day rules. So hopefully you're all familiar with sick day rules. So it's just a reminder, because they are particularly important in our CKD patients, because we're trying to, with the sick day rules, we're trying to avoid the risk of an AKI. And obviously our CKD patients are going to be at higher risk of an AKI. There are lots of different acronyms. SADMAN's one that I tend to sort of see, probably the most comprehensive, that kind of lists the main medicines that you really want to think about. I think sick day rules have kind of had quite a bit of controversy over time around them, around how we use them and which patients we give them to, because there's a very, very real risk. And I think anybody that's done any kind of CKD reviews or other reviews where you've given sick day counselling, you may have come across patients that it's really confusing for patients, that you're saying that when you're unwell, this is not good for your kidneys, but the rest of the time it's really good for your kidneys, and it feels very contradictory. And so you will get patients who perhaps struggle with that messaging and struggle with organising their medicines, and they stop taking them, and then they just don't start taking them again because they go, well, I don't know, this is really confusing. There's obviously a risk there, so maybe I'm safer just not to restart them. So perhaps for those patients, you might make a clinical judgment that actually it's safer not to counsel them on the sick day rules. But certainly if you think the patient can understand that and implement that, then in the ideal world, we should be stopping them temporarily where patients are systemically unwell. So people who have got fevers, diarrhea, vomiting. So really thinking about where their fluid balance is impacted and they're going to be dehydrated, because that's when these medicines start to be more risky for the kidneys. The hyperlink there does take you, I think that's the link. I'm trying to remember what I put on that QR code. I think it's to the Scottish webpage, because they've got some really good patient leaflets. There is also a link to sick day rules in, I think, the hypertension template on Ardens, and there's sick day guidance. So the one that the picture of there is from Salford Royal, who've done one. They've got a big renal department that they've sort of developed that. And so there's various different sick day rules or guidance available out there. It doesn't really matter which one you use. It's just about finding something that's going to be appropriate for your patient, that your patient is happy using, and that you're confident your patient understands, and making sure, so it's not the sort of advice that you would ever send out over an AccuRx. It would need some counselling and judgment that that's appropriate for the patient in front of you as well. Okay, have we got any questions with where we're up to?
No, we're all good.
Excellent, thanks Mel. Now, our next slide, we're going into management. I'm just wondering whether we give people sort of 5 minutes just to take a breather, because I know obviously we had the session just before, so people have been going nearly an hour. Is that all right?
Yeah,
I
that's
just think
perfect.
it's a good break point. Is 5 minutes enough?
Yeah, I think that's fine.
Yeah. Well, I've got 57 on my clock on my laptop. Should we say if people could come back for 5 past, and then we will crack on in management and get into all the druggy stuff and do the case studies?
That's perfect. Thank you.
Fabulous. So if everybody could come back for 2 past, please.
Philippa, there was a message. I did send you a message just about your slides. I just wanted to double check you're happy for us to share.
There is a caveat to that, but I will have a
Okay.
conversation with you afterwards.
Yeah,
I might just need to
course.
edit a couple of bits, because we've got some
no
draft
problems.
guidance that still needs signing off by the ICB. We've been having lots of conversation. We will discuss that. We're going to share it just because I think it's really helpful, but
Yeah.
we have promised not to. We're going to share it on the slides, but we promise not to circulate until it's
okay.
because
That's
it's
fine.
still going through approval processes. So what I might have to do is just do some editing of slides and bits before we share them.
Okay, yeah, that's fine. Perfect. Thank you.
Welcome back, everyone. Just going to share the screen again. I can see that there were some comments in the chat that some people are having some difficulties with the slides. It seems that it was quite small numbers given the number of people on the call, so I'm assuming everybody else can see them, and that's just individuals. But if lots of you are having issue, please do share. I know that there are clever people in the background as well that might be able to help you, but I will presume that that is perhaps issues your end if the majority of people can see them as well. So if we start again with our slides, so we're going to go on to the management section now. So we're going to go through sort of the pillars of treatment, if you like, for CKD. So we're going to have some slides on blood pressure control, and obviously the RA system antagonists would be sort of part of that management, but obviously we know they have impacts beyond blood pressure control, particularly on the albuminuria. And then we're going to talk about SGLT2s, which I know some people are definitely more confident than others. MRAs, so you might be really familiar with spironolactone and eplerenone, but phenynerone probably seems very, very foreign to you. You may have even never even heard of it, so you may be, oh, I don't even know what that is, what we're talking about. So we're going to cover some slides on that, and we're going to talk about lipid management as well. So some of this I think will be really comfortable, will feel really familiar. That blood pressure control, your ACE ARBs, and the lipid management is all bread and butter stuff, I'm sure, for all of you. SGLT2 is probably a bit of a mixture, and we know that MRAs is probably a bit more foreign in terms of CKD management, but we're going to go through all of that with you, so hopefully that will all make a bit more sense by the end of it. So before we sort of jump into the drugs, and I know I am a pharmacist, but it isn't all about just about the drugs. The lifestyle modifications are really, really important. And so we've got some bits on there, but that lower alcohol intake, that having a healthy weight sort of within the BMI sort of recommended guidance, that physical activity and the smoking cessation really have an impact on sort of long-term CKD care. And they're really what we should be sort of driving home those messages right from the start. And the earlier that people start getting those messages and start to engage in some of those things, the bigger impact that can have. And so really sort of thinking about that and how can we do that. And I think sometimes as clinicians, we don't always have time to do that. We're often quite focused on the drugs or the prescribing. So I would encourage you to think about who else have you got in your PCN that can support that? Have you got health and wellbeing coaches that you can refer your patients to? Do you have care coordinators? Do you have social prescribers that can support and signpost to some of these lifestyle modifications? So think about who is there in your team that can support you in delivering some of these messages where you might be perhaps needing to focus on other parts of the management as well. And I think one of the points actually, I know Georgina, you said yesterday when we were chatting, was about actually it can be really powerful to kind of have that discussion about lifestyle right at diagnosis, because at that point the patient's probably more motivated to do something about it as well.
There's quite a lot on the West Northants and East Northampton websites. So if you look up sort of West Northamptonshire smoking cessation or West Northampton weight management or alcohol reduction, there's quite a lot of helpful stuff on there. I find I spend a lot of time showing my patients how to Google these things in clinic, but if you haven't got time to do the formal counselling, that's a quite good resource that's available. And the West Northampton and North Northampton websites are very much mirrors of each other. It's very similar.
And I think the sort of your care coordinators and social prescribers are really good at signposting for some of those things as well. So that's sort of, even if you've not got time to do it yourself, sort of send them to somebody that can as well. So back over to you, Georgina.
Absolutely. So with CKD, optimizing blood pressure is so important. You will see people whose GFR is going down, down, down. And the moment there's a major intervention in terms of blood pressure control, it slows the rate of decline. And I show patients graphs of rates of decline on a regular basis. So you cannot underestimate the importance of getting that blood pressure down. If it's lower than it was, that's great. But if you can get it below the targets on here, so if they've got proteinuria, we want their blood pressure less than 130/80. It's not a target blood pressure. We're not aiming for 125 to 135. It's not like the INR. That's the maximum average blood pressure we're after, and that's a clinic blood pressure. So if they're doing them at home and they're getting to 125/70, that's far better. So in general, the lower the better, as long as they're not getting dizzy and falling over, is my general rule. But certainly we want the blood pressures below these levels. So if they've got no proteinuria, we say 140/90. Though as a nephrologist, I aim for 130/80 on almost everyone. But if they've got proteinuria, then definitely want a lower blood pressure. And if they're diabetic with proteinuria, then 125/75 would be preferential. In terms of what do you go with first, if they're diabetic, then generally your ACE and ARB, your RASI therapy would be your first line. If it's just hypertension, you can still follow the previous guidance, which is dependent on age and whether you go in with a calcium channel blocker or an ACE and ARB first. But if they've got additional CKD, most people are requiring 2, 3, 4 blood pressure tablets. So we're really just cycling through all of them. One of the issues that we have is that blood pressure medication titration is too slow. I was trying to get a slide off of Mike Breedes, the diabetologist, yesterday, because he showed me a slide before showing it takes 7.5 years to get someone from sort of first dose to maximal dose of diabetes medications. And I'm sure it's quite similar to that with blood pressure tablets as well. So personally, I give my patients permission to go up a dose if it's where it's possible, but I know that's more difficult with different clinicians and different patients. But certainly we need to start and titrate. We need to make sure the titration is relatively quick. So if they've got proteinuria, then you want your ACE inhibitor or angiotensin receptor blocker first. If they get a cough with the ACE inhibitor, just get them straight on to the equivalent dose of angiotensin receptor blocker. You don't need to go back to the bottom dose, and try and maximize them. If they've got proteinuria, it isn't just about the blood pressure, it's about reduction in the amount of protein that's leaking from the kidneys as well, because the glomeruli are like little filters, and if the blood's going through at a very high pressure, you get more leakage of protein and you get more damage to those filters. So lowering the blood pressure protects the kidney as well as protecting the rest of the cardiovascular system. So once you've got them maximised on their ACE or ARB, then you go in with the calcium channel blocker, and then quite often the indapamide next. What we find is indapamide also helps if you're getting a bit of hyperkalemia with the ACE or ARB. The indapamide will help bring the potassium level down, which is really helpful. Any particular, I'm just having a look. Is there a blood pressure that's, yeah, I've just seen a question. Is there a blood pressure that's too low for CKD patients? In general, what I would say is if everyone was healthy and had wonderful lifestyles and didn't have sort of westernized aging, our blood pressures would all be the same as they were in our youth, which would be about 110/60. So actually, I would say is the blood pressure that's too low is the one that's going to make them feel dizzy and fall over. And certainly, you know, I say to my patients, if they're getting somewhere between 110 and 125 and they feel well, then that's absolutely perfect. That's fine. If they've got significant proteinuria, then I want them on the maximum amount of ACE inhibitor they can tolerate without feeling unwell, but keeping their blood pressure really above 110 systolic. That would be my personal view. There's very little guidance. If you actually look at I'm not sure if you've all seen sort of U survival curves where you've got it's things like blood pressure. As the blood pressure goes up and up, the blood pressure, the risk of mortality goes up. But as you go down, it generally goes down until you get to 115/60, I believe. But certainly lower. If you're keeping it above 100 and they're not dizzy, you're generally okay. Next question was, how should we review blood pressure after ACE or ARB introduction? I'm doing 4 to 6 weeks. There's always thought they took longer to work. When I'm seeing patients, we're not waiting that long is the honest answer, because what I say to people is we can always take a step back. The likelihood of us overshooting is quite low. When someone comes to you with a blood pressure of sort of, you know, 140, 150, well, 150, 160, 170 quite often, the chances of them getting down to below 130/80 with one single dose titration is very small. You're likely to bring them down by only sort of 5 or 7 systolic on any given medication. So if you've got a long way to go and they're not dizzy, I'd be quite happy with them titrating once I've had the blood tests and it's been okay. So I'd be titrating the ACE inhibitors on the ward every 3 or 4 days. If I'm seeing them in clinic on a sort of more frequent basis with another condition, I'll certainly be titrating them every week or 2. But certainly I understand that in the sort of in the real world we can't be reviewing patients that often necessarily, but I would certainly be happier to be titrating more often if I thought there was a high risk patient. If you can be seeing patients and up titrating for 4 to 6 weeks, that's fine. But if you're going to go, I suppose the other thing to say is you look at the patient in front of you. If they're young, robust, and they've got a blood pressure that's through the roof, you don't necessarily need to start with the lowest dose. You can go in with a mid-level dose and then titrate to the maximal dose in 2 steps. If you've got someone who's relatively old, relatively frail, who you're concerned about postural hypotension and falling over, then you're going to go in with the smallest dose and titrate slowly. But if it's someone who's relatively robust and you want their blood pressure quickly controlled, you know, go in bigger steps. But I suppose that's changing it to the individual that's in front of you. With the amlodipine, that's quite long acting. You're looking at sort of 72 hours for it. I think 50% half-life. I'm sure Philippa will have a better number on this, but it's quite a slow on, slow off. So there's a bit more of a move towards waiting a couple of weeks for that. But I think none of them need 4 to 6 weeks. I think within a week or 2, you're going to peak their effect, in my view. I suppose the only difference to that one would be diuretics, when you're gradually offloading fluid. So that might be a little bit slower for some people. Okay. So sorry, my screen's changing. So what do we worry about when starting RASI? So GFR drops. There is actually good evidence that those patients who get the biggest GFR drop from RASIs or from the SGLT2s that we're going to see shortly actually have the most protection. And that's to do with the pressure in the glomeruli. At the end of the day, if the pressure of the blood pressure in the glomeruli is high and it's pounding and they've got proteinuria, you're getting more damage and more protein loss and more cardiovascular risk. And the way the ACE and ARBs work is they're acting on the efferent arteriole, so the little muscle on the blood vessels going into the kidney and reducing that pressure in there. And those patients that get the biggest reduction in GFR, and at the end of the day, if you're reducing the blood flow into glomerulus, you're going to be reducing the GFR, glomerular flow, into the kidneys, you are going to see a reduction in GFR. So as long as the GFR change is less than 25% from baseline, or less than 30% if you're looking at creatinine measurement, we are happy to persist with that medication, with the proviso that you recheck it after 1 or 2 weeks and make sure it's not gone down any further. So if you get a 15% or 20% reduction in GFR on your first measurement, but then it's the same or slightly better on the second measurement, that's fine. If you get a reduction and then you recheck it a couple of weeks later and it's gone down even further, then that may then that's going to be a judgment call and would possibly need stopping. I would tend to look at what else is going on. Is there any other medications being added? Have there been any other NSAIDs or anything like that that's come in? Have they had an episode of diarrhea and such like? But really, and the other thing to say is make sure you're looking at serial creatinine levels, because what you might be doing is comparing a high tide with a low tide, is the way I always compare it. If you look at all of the creatinines for the last 2 years, are you actually comparing the one that you're comparing to? Is it the highest one you've had in the last 2 years, or is it the average? So just check that it's a real AKI before you stop it, because the patients who are most likely to have the creatinine rises and the GFR drops are those who are most at risk of having the complications of chronic kidney disease, such as heart attacks and heart failure and things like that. So if there is a ongoing reduction, then clearly it needs to be stopped, but that might be an indication for also referring or getting some advice from the renal team. I know a lot of my job, I run a heart failure MDT with the heart failure nurses, and a lot of my job is to give them permission to restart ACE inhibitors when they've been stopped for AKI, or to look at the trends and say, actually, yes, I think the risks here, the benefits here outweigh the risks. But if in doubt, feel free to ask our advice. You will get our advice quite quickly. The other issue is potassium, and I've got a sheet in a moment looking at at dietary sheets. I know there is a dearth of a dietitian input in primary care, as there is in secondary care. We are really struggling to get any dietitian input. So a lot of what I'm doing at the moment is sending patients off to look up low potassium diet sheets themselves and get the advice from elsewhere. And I'll give you some advice about where to do that in a moment. So in terms of I think I spoke about what to do if blood tests are deteriorating beyond that. Obviously, if the potassium level is greater than 6, if you've just started it, you probably want to pause, think about what we can do, and then restart. If they've been on ACE inhibitors for a long time and potassium is more than 6, then really we are very keen to try and keep them on. I think the next slide's got things about artifactual potassiums and things, hasn't it? So we'll talk about that in a minute.
Yeah, I had a feeling the other thing, yeah, let's go on to the other slide because I know there's some bits that you mentioned.
That's it. I think we've got some more ACE slides coming up. That's it. So in terms of high potassiums, obviously patients need a potassium check 1 to 2 weeks after starting an ACE inhibitor, or a dose change is the other thing. It says don't start at the potassiums more than 5. If the patient really needs to be on an ACE inhibitor because they're diabetic with proteinuria, heart failure, etc., and we want to get them on that ACE inhibitor and the potassium is more than 5, then send them away to go and get the diet sheets. I walk into sort of wards where people's potassium's high and they can't have this, that, the other, and you see the bananas, the smoothie, the chocolate, the crisps, and it's all potassium, potassium, potassium. So the first thing to do is to actually get some dietary input. If you have got a dietitian within your surgery, please get them involved. If they haven't, then get patients to look up, if they're internet savvy, get them to go online and just Google low potassium diet NHS. As long as you put the word NHS on the end, you will end up with all of the diet sheets from all of the renal units in the country, and they're all really helpful. There's another website which I'm going to show you in a minute, which is related to Kidney Care UK, that's got some really good resources and really good recipes and things as well. And these resources you can use whether they've got kidney disease or heart failure or anything else if they've got high potassiums, but they're quite helpful. But in my experience, the majority of patients don't need Locum and expensive drugs. Most of them just need dietary advice, fruit juice, crisps, bananas, coffee are the main culprits. Steaming food and microwaving food and oven chips is another. If you boil veg and get rid of the water down the sink, a lot of the potassium goes with it. So that's the sort of simple advice I give. And I'm happy to do a session on low potassium. Well, you'd be better off with a dietitian doing it, but I'm happy to talk about low potassium diet a little bit more if it's helpful at the end. So disease modifying therapies should not be routinely stopped or down titrated. And that's because the patients who are getting the high potassium are the ones who are often those who are most at risk of developing complications of their disease. So in terms of what do we do if the potassium is high, if it's above 6, then they obviously need to have their little recheck is the first thing. Quite often it's artifactual. The blood test got taken in the morning at the surgery. It was difficult to get, slightly hemolyzed, got sat there for a few hours. The other thing is all of community blood tests get processed last in the hospital lab. So when you take it in the morning at the surgery and it gets shipped into Northampton General or Kettering in the afternoon, they then do all the hospital use and ease for the day and then put yours on the analyzer last. So quite often it's 2 in the morning we find potassium at 6.3, and quite often it's hemolyzed, sadly. So the first thing to do if you see a potassium that's a bit higher than expected is recheck it. If it's above 6, they're obviously going to need a ECG check and a recheck, and that requires a trip to local emergency department quite often. If it is confirmed to be high, if it is sort of 5.5 and above, if it's a good reason to be on an ACE or ARB and it's below 6, I keep it going while thinking about what else to do. But certainly if it's above 5.5, you still want to be thinking about what can we do to lower it. So the first thing is to stop other potassium sparing medications where you can. And to stop the NSAIDs if they've got some NSAIDs sneaking in when they're not meant to. Talk to them about diet and check whether they've been having lots and lots of Costa coffees the day before. and then consider getting some advice from ourselves. In the long term, we're hoping that Locum will be available in primary care, but at the moment it does need our input. But if you contact us, we can give that advice. If they're acidotic, we quite often will start them on some sodium bicarbonate tablets. If they've got a bit of heart failure or fluid overloaded, or they're not on indapamide already, we'll quite often add on a diuretic to actually get the potassium out of the system. Very rarely am I actually requiring Locum use, and I've got the patients with the sort of most severe CKD, so most of it can be managed in other less expensive ways. Is there, I think I heard a question. Yeah, no. I've just put this in just because it is a really, really wonderful resource. Kidney Care UK has got loads and loads of information about chronic kidney disease and how to manage it, and you know, diet in terms of low salt, etc. But it's also got lots of really good recipes for those that are on low potassium diets. I think somewhere I saw a note saying that they shouldn't be on a low protein diet. We're talking about potassium at the moment, but essentially I try and not restrict any of my patients' diets unless I need to. So they don't all go on a low potassium diet. I don't put very many people on a low phosphate diet, for example. But if they do need it, quite often they feel like you've taken loads and loads of food away. But this website's got loads of really good recipes for how to make sort of mince pies, how to make curries, soups and such like, all the things that they might feel they're restricted from. If they go in there and just tick the low potassium diet box, they'll get something like 250 nice recipes rather than sort of plain food. Okay. So modifying risk of chronic kidney disease progression. So if is this my slide or yours, Philippa? It's still me, isn't it? Yes, that's fine.
So sorry, I was trying to find the mute. I was just trying to share some of the links to the webpage in the chat. Sorry.
That's it. So in patients without diabetes, if they've got proteinuria, then they should all be on an ACE inhibitor and angiotensin receptor blocker. And then once they're on the maximal dose of that, they should be started on an SGLT2 inhibitor. And at the moment, dapagliflozin and empagliflozin are the ones that have had the studies in chronic kidney disease and therefore are recommended. I believe that it is a class effect, and I don't really mind which SGLT2 inhibitor is initiated. I think it's going to be the same as ACE inhibitors in the future, that we're going to be using them all. So dapagliflozin and empagliflozin are both 10 milligrams once daily, regardless of the GFR or the ACR, if you're using it for chronic kidney disease and as an indication. So that makes it very easy. The guidance is that we should up titrate the ACE inhibitor to max and then add in the SGLT2 inhibitor. But the evidence is that SGLT2 inhibitors are reducing admissions to hospital with heart failure and other complications within 3 weeks of initiation. So while the NICE guidance says this is what we should be doing, if you actually talk to us clinicians within the hospital, we're quite often starting them simultaneously, or starting them on a bit of ACE, adding in the dapagliflozin, and then up titrating the ACE. We're not following NICE guidance. We are very much trying to get these medications in as quickly as possible. Would be, and when I spoke to Mike Paredes, diabetologist, yesterday, he actually says that quite often he starts the SGLT2 inhibitor before he puts them on the ACE, which is, as I said, it's all not necessarily what the guidance shows. I know that you'll be keen to follow the NICE guidance, but certainly if you've got a patient who's got symptoms of fluid overload, for example, you know, or you think they're at particularly high risk of heart failure, please just put these medications in early. And as I said to you already, from my point of view, you can titrate very quickly. If they've got proteinuria, you want them on the maximal tolerated dose. You're not necessarily just aiming for a blood pressure target. In patients with type 2 diabetes, the proteinuria cutoff for starting these medications is 3 milligrams per millimole rather than 70. And once again, it says to optimize the ACE or ARB, but if they've got proteinuria, there isn't too much ACE or ARB. It's the ACE or ARB that doesn't make them fall over. And then adding in the SGLT2. Now, if they've got a normal kidney function, so if they've got CKD 3A, and fairly good kidney function, and you add in a SGLT2 inhibitor, you're going to be reducing their blood sugar levels. HbA1c goes down by about 1 in old numbers. I'm not quite sure what that is in new numbers. So if they're on insulin, for example, already, you may need to reduce their insulin dose a little if the HbA1c is well controlled. If they've got HbA1c of 70, then, you know, or above, then you don't need to modify anything at all. But you've got a slightly increased risk of hypos if they're on other medications that cause hypoglycemia already. If your GFR is low, 45 or below, then these medications are almost certainly not going to affect your blood sugar levels, because actually what we found in the studies of patients with advanced with CKD 3B, 4, 5 was that patients were getting all of the renal benefits with no reduction in HbA1c. So for those patients, you're just adding it on as if you were adding on an extra ACE inhibitor. It's very much having the same effect, but probably a slightly bigger effect than that in terms of the reduction in proteinuria, reduction in risk of progression of chronic kidney disease, but you're not affecting their blood sugar levels. So if someone's got a GFR of less than 45, you do not need to modify their diabetes medications. Okay. And then in terms of the next modification, if they've got type 2 diabetes, then finerenone is recommended for those with the highest risk of progression, which is those that have got GFR of more than 25, but an ACR of more than 3 as well. But finerenone should not be used with other heart failure medications such as spironolactone and eplerenone. Anything else you want to say on that slide, Philippa?
No, I think just to reassure that we are going to go into SGLT2s and the finerenone in a bit more detail on the sort of coming slides. So don't worry if you've not quite taken that all in. It's a bit of an overview, and apologies for the typo because that's less than 25. So just to highlight, as Georgina just said, it's greater than 25.
Indeed. That's fine. Oh. Okay. This nice picture's in here because this is the theory as to how the SGLT2s work. They act on something called a sodium glucose transporter, and essentially salt is swapped for sugar somewhere in the kidney, and that's how they think that it takes has its effect. In practice, these receptors are all over the body, not just in the kidneys, and in the studies, when patients actually get to the point of end-stage renal failure and are on dialysis, they still work because actually in the gut and in the heart and everywhere else as well. So the honest answer is we don't truly know why they work, but they work very well. As I said, the HbA1c drop-in is only in those patients who've got good kidney function. If your kidney function is poor, you don't actually excrete that much sugar. So sodium is swapped for sugar in the tubule, and the sugar is put into the urine and put down the toilet, which is why all patients that are on SGLT2 inhibitors will have 3 or 4 plus of sugar on their urine dipstick. And if you're checking a patient's compliance with their medications, it's a really good way of checking. You get those patients who come along and say, yeah, I'm taking everything, and they've got no sugar in their urine. It's like, nope, that's not true. So the sugar loss is responsible for some of the weight loss you see in these patients, as well as the diuresis and loss of fluid, which are both quite helpful. But as I said, it's also a good way of checking compliance. Patients will get weight loss due to sugar loss, but they'll also get weight loss due to diuresis. I've generally found that patients require a bit less diuretic if they've got heart failure when they're on SGLT2s than if they're not. Patients' blood pressure does tend to lower. They're not antihypertensive medications, but as you take a bit of fluid off, you tend to see a little bit of a lower blood pressure. And the lower interglomerular pressure is why you get a large reduction in proteinuria, and this is there's a slower rate of progression of proteinuria and GFR once they're on these medications. We have seen the occasional patient with an increased hemoglobin levels. I've had a few I've sent to hematology clinic with polycythemia, but I'd exclude other causes before I blame the SGLT2 for that. Yeah. Good. This slide, sorry.
Sorry, I wasn't sure if you were quite finished.
Right. This slide shows all the studies that have been done in patients with chronic kidney disease, looking at which patients were included according to their GFR and albumin levels. And you will have these sort of empagliflozin drug rec come around and tell you that their drug should be used because it's been shown to work in patients who have got more advanced kidney disease, less advanced kidney disease, more proteinuria, less proteinuria than everyone else, and therefore it covers everything. Dapagliflozin was one of the first that was shown to have good outcomes in chronic kidney disease, but they had a more select group of patients, though obviously we were already widely using it with heart failure, so we're a little bit more familiar with it. But this is obviously what we're told. Most of these, in my experience, they are a class effect, and in my experience I don't have a particular preference for which we use. I've tended to use a lot of dapagliflozin because it came out and was licensed for the heart failure patients first, and so many patients I see have got heart failure as well as CKD and diabetes, that was the one I tended to use and had the most familiarity with. But I'm now using more dapagliflozin as well, and as I said, I have no preference. My main message is please get your patients on SGLT2 inhibitors if they're allowed to be. That's my main message. There is something like a 30% reduction in risk of admission for heart failure. There's a reduction in all-cause mortality. These are definitely excellent medications to be on. They slow progression of chronic kidney disease. When you first start someone on them, they will drop their GFR, but in the same way as an ACE inhibitor, if you stop it, it will come back up again. So you don't have to worry about speeding up the kidney function. You have to explain to the patients that it's just an artifactual drop in GFR, that the rate of slowing the kidney function is reduced, and if I was to take you off it, you'd be in a better position being on it than if you weren't. We do see the occasional patient who comes in with an AKI due to SGLT2 inhibitors, but it is very occasional. And you can seek advice in these situations. It tends to be those who've got renovascular disease that hasn't been identified. Very occasionally we get people get a tubular interstitial nephritis with it, but they're rarities. The benefits from these medications are massive. So SGLT2 patient counselling. Ketoacidosis is really rare, and if patients are sticking to sick day rules, we shouldn't be seeing this too often. One of the contraindications is type 1 diabetes, but actually I'm now seeing quite a lot of patients who aren't being given it for chronic kidney disease. We're not saying we should put type 1 diabetics on it, but we are seeing it used in patients who've got type 1 diabetes and heart failure, for example. And even in those patients, the risk of ketoacidosis is rare. So as long as you're letting people know that they should avoid it with sick day rules, that's fine. I have had some patients who've only had a letter, not had the explanation, and they've then got quite scared of these medications. So I think, as Philippa said before, it's explaining the sick day rules as well. The patients who I've had to avoid it with are those who get recurrent urinary tract infections. If it's just the occasional urinary tract infection, I just counsel the patients it's more likely to happen. You've got sugar in your urine, then you're more likely to get a urine infection than someone else. If you're diabetic with a HbA1c of 70, you've got sugar in your urine anyway, to be frank. I don't think it is a massive increase. But those who've got long-term urinary catheters, those who've got recurrent urinary tract infections as a cause of their chronic kidney disease, often don't tolerate SGLT2 inhibitors. So we've really got to weigh up the risks and benefits in those patients. I explain to my patients the most common thing they're going to see is a bit of thrush, and if they do get a bit of thrush, then go and get some treatment for it. The necrotizing fasciitis is incredibly rare. I find it quite unfortunate we have to counsel people on this. I just mention the fact you can get infections down there and to get advice if they do. I'm not necessarily using words like necrotizing fasciitis and Fournier's gangrene in my counselling. They are slightly scary words, aren't they? But certainly patients are advised to seek medical advice if they get any infections down there. But as I said, thrush is the most common thing. The other thing was the very, very, very first SGLT2 that was shown to have benefit in chronic kidney disease was canagliflozin, and in that study there was a small signal suggesting that if patients had got diabetic foot ulcers, that there was an increased risk of amputations. Now that has not been seen in any other study of SGLT2 inhibitors since, but because of that risk we talk about it a lot. And in general, if patients have got ulceration and diabetic ulcers on their feet, we tend to avoid SGLT2 inhibitors. However, if they're in my clinic and, you know, quite complex with massive proteinuria and progressing, I quite counsel them and keep them on it as well. It's just a case of making sure you've explained it and documented and consented them for it. But if you've got those patients, you can send them to us and we can do that for you. But in general, if they've got infected diabetic, you know, if they've got open foot ulcers, we should be avoiding SGLT2s or holding them at that point until they're fully healed. In terms of contraindications, we've got children, pregnancy, breastfeeding, liver disease, bilateral renal artery stenosis. It's got organ transplant, but all of those patients are under specialist advice. I am using it in patients with organ transplants. I am using it with patients with lupus nephritis and ankylosing. And the reason for that is they've got an increased risk of infections due to the fact they're immunosuppressed, but actually these patients have all got a high risk of progression as well. So it's just balancing up the risks and benefits in those patients. Polycystic kidneys, I'm not, because they get a infection in their cyst. It's a bugger to treat, and those are the ones that we're avoiding, but they're normally under us as well. And active foot disease I've just mentioned.
Thanks. I just wanted to add, I think Georgina and I had a conversation about this because we're really conscious that in primary care, CQC audit whether we are counselling on SGLT2s, which is, I personally feel is very counterproductive, because obviously we should be counselling on all medication and they don't audit anything else. And I think the result of this is that often all the information gets sent out, perhaps without being targeted to sort of the relevance for patients. And when you think about consent and speaking to patients about medicines and weighing up risks and benefits, as any clinician, you'll make that specific to the patient in front of you. And if you just send bulk send information on all the risks, actually I think it can be really counterproductive in terms of concordance and compliance. And I guess we recognise that, and I don't think it's great. I think actually we really possibly need to think about how we lobby against CQC auditing that particular thing, because I think it becomes really counterproductive. So I think, Georgina, that run through of those side effects was, I
might add a comment there actually. So when I was a medical student, they used to admit the occasional person to start them on ACE inhibitors, because when ACE inhibitors came in and we saw the reduction in GFR, we were quite scared of them because it was a lack of familiarity. And I think with the SGLT2s, that's what's happened. When they came in, there was a lack of familiarity, and that's why all of these, you know, big ideas about how we should consent people came through. So I think what we need to do is actually show the evidence that the risk of these things are relatively low, and then push back on it. You know, we wouldn't dream of admitting someone to start an ACE inhibitor anymore, would we?
No, absolutely not. So I think really is some reassurance about those patient counselling points. And I mean, I know certainly speaking to Georgina and listening to her speak there as well, I know I'd use that sort of to go and reassure my patients that perhaps they don't, you know, we may have sent them a leaflet or they may have read that, but absolutely giving some context for that and some reassurance that they're not terrifying drugs. We're just having to give them all the right information. I mean, you look at a patient leaflet on paracetamol and there's a massive list of side effects, but if you started sending that out as we've noticed you're on paracetamol, you'd have no one taking that either. So it's about explaining relative risks to patients and kind of giving them some context for that. I think it's really important.
I think the other thing I mentioned to my patients is the number needed to treat. With majority medications, you're looking at 70s, hundreds of patients you have to treat to have one beneficial effect. With the SGLT2 inhibitors, my understanding is it's more like 20 or 30 patients that you need to treat in order to prevent a hospital admission or an event of some description. And when you explain to the patients that actually these are more effective than almost any other medication they're going to be taking in terms of outcomes, and try and put this in context, I find that's quite helpful as well. Okay. Lipid management. The NICE guidance says we should be putting all patients with chronic kidney disease on atorvastatin for primary or secondary prevention, and that is regardless of their actual cholesterol level. To be fair, I won't say it's evidence-led, because actually the only study that's ever been RCT that was ever successful in the renal world, because they all fail one way or another, was a study of simvastatin and ezetimibe in CKD4. But we know in practice that atorvastatin has better cholesterol lowering properties and works better in general than simvastatin. So I'm happy with this plan. But essentially all patients should be on atorvastatin 20, unless their cholesterol is actually higher, in which case you're allowed to increase it, or unless they've got another reason for being on a high dose. So if they've had a myocardial infarction and the cardiologist has said to start them on 80, please continue 80. But if they're not on anything, please put them on 20. And I explain to patients that it's one of those things, it's not about checking the cholesterol, because they all come up and say, what's my cholesterol? It's no, the lower is the better. The evidence in general for those patients in the study, which wasn't atorvastatin, but is that being on it is an important thing, and that's therefore what the NICE guidance is. So as long as patients do tolerate a statin, please put them on atorvastatin 20. If they don't, then obviously we have a fiddle with other statins and ezetimibe and things like that. Neither the atorvastatin or the ezetimibe need any dose titration in renal disease. They're not cleared by the kidneys. And they're generally considered safe. Lots of patients are worried about aches and pains. And I've said at the time, the aches and pains are attributed to the atorvastatin, but not caused by the atorvastatin. We all get aches and pains in our old age. If we're on a statin, we blame it on that. If we're not on atorvastatin, we blame it on yesterday's gardening or Pilates or whatever else happened yesterday. So patients that do tell me they've got aches and pains, I tell them to stop it for 2 weeks and then restart it for 2 weeks and see whether it's truly related or not. That's my general advice.
Regina, can I just jump in? I just want to clarify. I know you said it doesn't need any dose titration, and I think you meant as in you don't have to reduce the dose due to renal impairment, but you can titrate it up. And so if you are using it for secondary prevention particularly, obviously you may well want to titrate that up, but that's just a case of getting them started on it.
Absolutely. So everyone should be on 20 minimum if there's not a contraindication. If their cholesterol is elevated, then please feel free to titrate it up. If they need 80 because they've had a heart attack and it's for secondary prevention, please put them on the 80.
Absolutely. Thank you for clarifying.
And we quite often, it gets stopped when patients come in with AKI. But actually, if the AKI recovers, please restart it. It's very rarely the cause of AKI. The only patients that really get an AKI due to atorvastatin are those that got rhabdomyolysis, and that is extremely, extremely rare. I see about 3 or 4 cases a year, and that's from all of your surgeries put together. And it's normally because they've had a long lie. It's got nothing to do with the statin. Okay, oh, there's a question. How about if a patient needs to be on ramipril, but creatinine clearance is dose adjusted? Oh, we're going to talk. Have we got any more talk about ACE inhibitors at the end?
I don't think we have. If you want to cover that now, I think that would be absolutely fine.
No, that's fine. So there was a conversation and there's a question about maximal dose of ramipril. So the maximal dose of ramipril, if the GFR is more than 30, then the maximal dose is 10. If the GFR is less than 30, then the maximal dose is 5. But that's purely because between doubling the dose from 5 to 10 in renal impairment doesn't make it work any better. But in practice, it doesn't cause any harm either. So if someone's on a bit too much ramipril, it's probably not going to cause them any harm. If you're monitoring the kidney function, it's just that it peaks its effect at 5 if the GFR is low. Right, finerenone. None of us have got much experience of this because it's only really sort of started becoming available, and we've only just started having the approvals to use it. And actually, lots and lots and lots and lots of patients should be on this, but I haven't met them because by the time they get to me, it's too late. So really, one of the reasons I'm here is to talk about finerenone and get this added on. So those patients who have got a GFR of more than 20, those patients with chronic kidney disease due to diabetes, type 2 diabetes, that are already on an ACE or ARB and an SGLT2, who've got proteinuria with an ACR of more than 3 and his GFR is more than 25, should be on finerenone as well. And this has been shown to reduce their progression of chronic kidney disease and also to have cardiovascular benefits. It's in the same group as spironolactone and eplerenone, so it's not a new scary medication. It is in the same group as spironolactone and eplerenone and is sort of monitored in a similar way. But in our experience, it does not cause very much hyperkalemia. So as long as potassium is below 5 when you start it and you're monitoring it, we aren't seeing much hyperkalemia at all. If they are getting hyperkalemia and it's indicated, then all of the stuff I said before about low potassium diets and also the addition of potassium lowering medications can all be used, but essentially our patients should be on these. It's a mineralocorticoid receptor antagonist is the long words for it, but it's more selective than spironolactone and eplerenone, so it doesn't have the same sort of gynecomastia, it doesn't have the same risk of hyperkalemia. It would still need 6A rules in terms of stopping it if you get diarrhea and vomiting in order to reduce that risk. But this is the next drug that's on the market. There's going to be some guidance coming out shortly about how it can be used. It's still draft at the moment, but we're hoping to get that over the line in the next couple of weeks. And at the moment, it's green, but needs a specialist to approve it, which means that it needs if they've got CKD3A, and proteinuria, and they wouldn't need to come to us for any other reason, then it just needs some advice and guidance and a yes from us. But we'd be more than happy to review these patients if you feel you'd like us to. But it's a safe medication. In the short term, you need our permission, but in the long term, I'm hoping that we can get you initiating it in primary care, because as I said, it's going to keep patients well and actually keep them away from me. I don't need to see so many patients if we slow their progress, and that's the long-term aim. If there's some questions coming in on that, I'm hearing is this going to be licensed for heart failure patients? I believe so, but I'm not, but I can't give you a heads up on that. What I would say is there's so much crossover between heart failure and diabetes and CKD, that essentially I just pick which indication gets the drugs I want into people at the moment. Because in the same way, what we haven't written on here is the GLP-1s. It's very topical at the moment, but we are waiting for the studies to come out to give us permission to use them in CKD and not just diabetes, because we know that they reduce proteinuria, they reduce progression of chronic kidney disease, they reduce the risk of heart attacks by sort of 20% or so in our diabetic patients. So almost every diabetic patient I can get on a GLP-1 at the moment, I am. And I'm going to be the same with the CKD patients with the GLP-1s, which isn't for unknown. I'm going off topic, but it is one of my passions in life, is trying to get these medications into people when I can, because the benefits are so huge. And with finerenone, yes, it is going to be beneficial in heart failure patients, and hopefully there'll be some more news soon. But if they've got CKD and heart failure, then you can use it for that reason.
Would be off license, so just a word of caution. I know Georgina's much happier doing things off license.
Yeah, but as I said, if they've got CKD and diabetes and heart failure, you have the indication for using it on license. That's what I'm trying to say. So when people come into my clinic, I don't just look at the CKD. I try and uptake. One of my other passions is trying to get patients' medications up titrated. So if they come to me and they've got heart failure and the heart failure medications aren't up titrated yet, then I see it as my job to up titrate, you know, the diabetes medications, the heart failure medications, everything we can, because these patients are in so many different clinics, seeing so many different people with so many different medications, that if we can optimize everything on one visit, we'll get to the sort of the peak optimal treatment quicker. Yeah. So in terms of finerenone prescribing, in general, most patients start on 10 milligrams once daily, unless the GFR is more than 60. And so if they're diabetic and with normal renal function but proteinuria, you can start them on 20 milligrams of finerenone, but for others it will be 10. The potassium should be less than 5 when it's started, but as I said, if it isn't less than 5, please give them some diet sheets and get them to repeat the blood test. And once it is less than 5, you can get them on it. And then you would check the blood test 4 weeks after starting or changing the dose. Most patients start on 10, but the potassium levels are satisfactory. You can increase it up to 20 a day. If the potassium level goes above 5.5, they say to withhold. That's probably quite cautious advice. I suppose the reason for being cautious is we know that patients who are on spironolactone, they get hyperkalemia and they come into hospital with it. It does persist for a good week quite often. So I suppose for that reason, 5.5 is probably a safe thing to do. But if the potassium is up, please get the other methodologies to get the potassium down rather than just stopping the finerenone. Would be my message. NICE referral criteria you will have all seen. And the main difference between this and the previous NICE, and I say this, it's actually quite old now, this guidance, it's not new anymore, was the addition of the KFRE. And it's really unfortunate that the KFRE is not automated and easy and flashing up on your screen. It would make it a lot easier. But as I said, please Google KFRE UK and you will get the equation, and it takes literally seconds to do in order to do that. So in terms of referral criteria, it's patients who've got a 5-year risk of needing renal replacement therapy of more than 5%, where you feel that it would be a benefit to send them to us. So not 92-year-olds who are bedbound, but you know, people who you feel would be of benefit from either having renal replacement therapy or at least considering it, or management of the complications of their chronic kidney disease. Those that have got an ACR of more than 70, which is not due to diabetes, or those that have got an ACR of 70 and declining kidney function and a KFRE of more than 5% with diabetes as well would be the other thing. Those with an ACR of more than 30 with hematuria, so it's got microscopic hematuria and proteinuria, they should be coming to us. Those whose kidney function is declining quickly within a year, so GFR drop of 25% or more within 12 months. Those whose GFR has declined by more than 15 mils per minute in a year, when it's not just an AKI, so a sustained drop means you've got to have checked it at least twice. We get quite a lot of referrals where there has been a drop, but it's not been rechecked. And the problem is that if it is an AKI, they don't really want to be waiting to see us in clinic. Our lists are not that quick. And those with poorly controlled hypertension, those who've got genetic causes of chronic kidney disease, and those who are suspected to have renal artery stenosis, which actually is those that if you try to put an ACE inhibitor and didn't tolerate it, would be those patients. Or those that you're worried about. At the end of the day, these are the criteria, but if you've got someone who's relatively young, you're not going to wait for it to be this bad before you refer to us. So if you feel that there's another reason for referring to us that isn't on that criteria, you know, the worst we're going to do is say no thank you. So please do send it to us if you've got concerns, or we can give you advice about optimizing therapy and when to refer. So these are the sort of the bare minimum for when to refer. But if you've got concerns, please let us know, or if you've got a question, let us know.
Thanks, Georgina. So as we mentioned, we've been doing some work on a local pathway. Now, we do have to caveat this, that it has gone to MPAG so far, and we've had some positive feedback from there, but it still needs to go through various ratification processes and approval by the rest of the ICB and the LMC. So this is by no means finalised, and unfortunately we can't officially share it, but we wanted to kind of share where we were up to, and obviously we will, when it is finally ratified and signed off, we would share that via a tablet press so that you're all aware of it, and it will be uploaded to the GP portal. So it's kind of a bit of a pulling everything together that we've talked about together and giving you a resource to be able to reference back to use sort of for ongoing care, because conscious there are probably in excess of 40 slides today, and when you're sat in clinic you need something that you can look at quickly and get the answer of what you need to do with the patient in front of you, and bits as well. So we are working on that for you as well. So there are 2 pages. They kind of, there's a bit of overlap between them, and that's partly because of input from different people, and you can never please everybody with one form. So there's 2 different pages. One is this heat map, and you may have seen this before, because this is actually a resource that was developed I think by GPs over in Birmingham, I'm trying to remember now, and they've given us permission to adapt and share this. So we've done a little bit of work on some of the wording and some of the formatting to try and make it a little bit more user friendly based on sort of local feedback as well. And what this does, if I just I'll put my laser pointer on because I got very excited when I had that earlier. It kind of uses this same categorization. So you've got your A1, 2, 3 across the top with your ACRs and your PCRs. And then you've got down this side, you've got your EGFRs and your G1 to 5. So we've talked about those quite a bit already. These little white numbers in each corner, as the key tells you over here, this is the monitoring frequency per year, and that's based on NICE guidance. So we talked about that earlier. So the ones up here are all the once a year, and then all the way down here you've got sort of 3 times a year, so that's your 4 monthly on that monitoring sheet we looked at earlier. So again, that's sort of pulling together some of the information from these earlier slides. And then what you'll also see in here is you've got lots of offerstatin all over the place, because we've just talked about lipid management. And then you've got where the SGLT2s start to come in. There's overlap within, say, some of these early groups. So this would just be if they were diabetic, which is why it's only consider, not offer. So you'd need to consider the requirements, but that's partly why I have reservations about this. And then where you've got perhaps further down, so like these patients where they've got the higher levels of albuminuria, you've got offer SGLT2s, because actually for these patients, we know that they are covered by the NICE guidance. So it kind of gives you a bit of a quick overview. There's a reminder at the bottom here about referral criteria, and some guidance here around sort of referral criteria as well, where you've got very high levels of proteinuria as well. So that's the first page that, as I said, in draft. And the second page, which personally I'm much more happy with, I'm a much bigger fan of this one, is starts off with your CKD at the top, your eGFRs less than 60, and then you can either follow either side, and you will probably see that we've tried to use sort of similar terminology and similar layout to what we've just been through in the slide. So hopefully this feels familiar. There are also links in here, so there are educational videos. So these have been produced by our tertiary centres. So these are Leicester videos. They're really patient friendly. They're really fabulous resource, but there's lots of different resources in there, from SGLT2 videos to UACR videos, so videos explaining to patients why we need them to get a UACR. So instead of just saying please provide a urine sample, you could have an AccuRx that has a video explaining what UACR is and why we need it, so patients are more likely to do it. But there's a whole host of videos that are free access, and we're able to use them, and Leicester are our tertiary centre, so it feels very appropriate for us to be using those, and we have permission to do so as well. And then this optimization of cardiovascular risk section. So we've talked a lot about this, or Georgina has, certainly with the medication. We talked about the lifestyle side of it, the lipid management side of it. And I think the really important thing is this box here is about doing this in conjunction with this. Don't do this and put off starting your ACE inhibitors. It is very much do this as well as starting your medication. And then we've got the optimization of blood pressure, which Georgina's just been through with you, and sort of separates out what the guidance and targets are. Again, this side being without type 2 diabetes, this side being with type 2. And then there's some additional guidance here. So you'll recall a few slides back, we had some slides on when to be worried. What are the okay parameters? Sort of that up to a 25% reduction in eGFR was fine, about some of the potassium guidance. So that's from this document that we've linked here, that's been produced by I think it's from the Renal Association. But some national guidance about ACE inhibitors directed at primary care, really friendly, helpful resource with tables that are quick reference guides to sort of support your prescribing. And then again, you've got down here, you're modifying your risk of CKD progression. So on this side, you've just got your DAPA and EMPA, which both licensed in your CKD population. And then this side, you've got your DAPA and EMPA, but also your canagliflozin, because obviously that's only licensed if you have type 2 diabetes as well. And then the finerenone that we've been talking about as well there. Just a reminder, I know there was a typo on one of the earlier slides, but I think the more recent ones have all been correct. That's greater than 25 and the ACR greater than 3. And obviously, as finerenone is an MRA, you shouldn't be using it with other MRAs, because obviously they're the same class of drugs.
Oh, I was going to add in a brief comment about the SGLT2s, that there's guidance about when they can be initiated in terms of GFRs. So on the dapagliflozin between 25 and 75, and with the empagliflozin between 20 and 45. But in both of those studies, the patients that started on them stayed on them all the way down to kidney failure and starting dialysis, and they were safe. So once you've initiated them, you don't need to stop them or dose reduce them when the kidney function goes down. They are safe to stay on them. And, outside of licensed conditions, I'm quite happily using them in patients with much lower GFRs. I'm quite often being a bit naughty and initiating them. So don't have any fear of those meds once the kidney function goes down.
Absolutely. We've got that highlighted in a case study in a minute, haven't we? too. So and then the last page really of the guidance that we've developed is got a summary of the NICE referral criteria, and there's a link to the KFRE that we've talked about as well, so that it's easily accessible. There's support and some guidance on starting SGLT2s. Obviously I've mentioned the videos that are on the hyperlinked on the first page, or the previous page, and then again some prescribing guidance on starting finerenone. Like Georgina said, you know, we know that there's not much local prescribing, and I think with a lot of new drugs we normally wait for the specialists to do it, and we kind of see how they do it, and then we sort of start doing it in primary care as we get a bit more confident in carrying on that prescribing. But the real problem with finerenone is that by the time the patients are getting to secondary care, as Georgina's already said, it's too late, and so secondary care aren't starting it, so then primary care are going, well, they're not starting it, so maybe we shouldn't. But actually it's to do with where they are in their EGFRs, and so, you know, it's these 25 to 60 is where we need to be starting it, and as a reminder, that's in your type 2 diabetics. So just trying to think, and I'm sure you can probably think of patients already who you're thinking, oh, actually I've not considered this previously. And then there's some notes on managing hyperkalemia over this side of the screen, and bits. And I'm actually thinking that some of the comments that we've talked a lot about diet, and I wonder whether actually including some bits in there might be a good idea. Obviously this guidance is still in draft, so perhaps putting some links to some of the advice that Georgina shared today.
The Locum, there is actually a shared care protocol now, I believe, for that's been, but once again, it's one of those drugs that despite having its on formulary, there is a shared care protocol. I know the sort of heart failure team have more use of it, but people don't have a great familiarity. But Locum is very easy for us to do as a shared care protocol. So if you have got people who've got persistently high potassiums who should be on ACE and ARBs, should be on finerenone, and they're not tolerating it, or spironolactone for that point for the heart failure, and they're not tolerating it, and you want our advice on how to use Locum, please let us know.
Definitely. Bits. So I think we've got some case studies, and I think we've just got just over 10 minutes. Are there any questions at the moment? Because I know I'm conscious I can't see the chat whilst I'm sharing slides. Are we okay? I'm going to take
the research team in
Corby
is wondering if they could speak to me for 5-10 minutes post call. The answer is not today, because I've got to run away to another meeting in Lutterworth at 4 p.m. So but I'd be more than happy to be contacted and spoken to anytime aside from that, or I can send you my phone number and you can talk to me on Bluetooth while I'm driving. But if you email me, it's my first georgina.ordus@nhs.net, and contact me. I'm usually quite quick to respond to my emails, and I'll very happily have a chat to you. But I've got to be in Lutterworth for 4, so but very happy to
crack on with our case studies, otherwise I'm conscious we're not going to have a chance to talk about those. So this first patient was a 70-year-old female, had a history of ACS, hypertension, type 2 diabetes and COPD. She had a KFRE of 5, so actually sort of, you know, that's highlighting she's quite high risk and potentially meets requirements for referral to secondary care. And she hasn't been referred to secondary care. You can see sort of lipids are there and blood pressure a little bit high, and she had a recent blood test where her potassium was 5.7. So you can see here that she's got some medicines that you probably expect to see, fairly sort of standard typical patient, and her ramipril had been reduced due to hyperkalemia. Now, hopefully you're all already thinking, having just sort of sat through the last hour and a bit of Georgina and I, that that actually maybe reducing that wasn't perhaps that you wouldn't necessarily do the same again, having sort of been through these slides, and perhaps there's some other things. Now, when that potassium then came back as 5.7, what then happened was the ramipril was stopped. The potassium did come down as a result of that, but the blood pressure was repeated, and then the blood pressure was even higher, and it wasn't great before, and then amlodipine was started for that instead. So I'm going to hand you over to Georgina now to sort of talk a little bit about what was the alternative, what could have been done differently, perhaps in hindsight. And hindsight is always a wonderful thing.
So we've covered lots of these things already. So the first thing was, is it artifactual? If every time they go up to A&E it's lower, then it probably is an artifactual thing, and I then get them to go to Northampton General to get their bloods done in future. Diet, signposting to those diet sheets, trying to get a dietitian involved if you've got that facility. Consider adding in indapamide, or if they're fluid overloaded, a loop diuretic that helps with the blood pressure as well as potassium. And then if they're still hyperkalemic, and it's a good indication, as there is in this case, for continuing with ramipril, then consider adding in Locum. If there's been a reduction in GFR as well as hyperkalemia, that would have initiated a referral to the renal team, would be the other thing to say here. But Locum is very, very effective. Locum is a drug that you swallow, and it binds potassium in the gut, and it goes down the toilet essentially, and you will take potassium from sort of 5.7 down to 4 and a bit very quickly with that, and that could be continued long term if need be. So there isn't familiarity with that, but it's a good medication, and it's very easy to use once you've initiated the blood test. Consider titrating the statin upwards, and we spoke about adding in the SGLT2 once optimized on the ACE, or perhaps even sooner. In someone like this, where you're not optimizing the ACE as quickly as you want to, that would almost be a reason for adding in the SGLT2 quickly, because it doesn't cause hyperkalemia.
Any questions on that case study before we go on to another one? I'm conscious we are rattling through these. We have only got 3 case studies, but I'm just keeping an eye on the time as well to try and get us done.
There's no questions.
Fabulous, thanks, Mel. So case study 2 was a slightly older gentleman, he's 77. It will hopefully become apparent why we sort of picked this case study to share. Now, type 2 diabetic, hypertension, hypothyroid, and some GI bits as well. His EGFR was all the way down to 24, raised UACR, and quite a high KFRE there, really, of 30%, although he is sort of 77, so we've got to think about so what's the long-term goal for his care. Similarly, we've got some lipids and a slightly raised blood pressure, and you can see there he has got some meds, but he's not on anything that we've just talked about at all. And so we did a little bit of digging to see why not. So obviously there was no ACE or ARB, and interestingly, when we looked right back in this chap's notes, he had previously been on losartan, and it got switched to ramipril, not really clear why, but either way, it didn't matter. He was on one or the other. We weren't really fussed about that. But in 2023, so sort of about 18 months or so ago, this chap's ramipril was stopped. And this is really why, this is kind of the learning point of why this case study is in, because although this is one patient, I think it's something very, very familiar with. And I think on that discharge prescription, it said hypotension, GP to stop. And so somebody had put a code on that patient's records to say that they were contraindicated for ACE and ARB because of the hospital, and didn't really explain that. And that meant that every other consultation that had been had thereafter, lots of very clever clinicians had reviewed that patient, but hadn't necessarily had the time to go back and look at what the reason was. But they were like, well, it's contraindicated, and the hospital said it's contraindicated, so we must never start this. So essentially, in the last 18 months, that patient's been, people have repeatedly considered and ruled out ACE and ARB therapy on the basis of this. There was a comment to say the patient had some hyponatremia as well, and in which case it might have been worth considering going back to the last losartan or back to another ARB bits, because that tends to cause less of that hyponatremia. But what had actually happened is the patient had ended up being put on amlodipine instead. So it's really just thinking about, when you get those messages from the hospital about stopping things, is really considering what codes are put on the record and what's documented in the clinical notes, so that you're not ruling out therapies for the future unnecessarily. And that on this occasion it was hypertension, but that could have, I've seen that as being AKI, and I know Georgina, you shared an example earlier as well, so it's really highlighting sort of some care when
and I would also make a brief comment about quality of discharge summaries. I think we all despair sometimes with the quality of discharge summaries, and they're not necessarily being written even as expected. So if you see something like that in a discharge summary where someone's tolerated it for so many years, please do ask that question if you get the time. I suppose would be my other question, comment. Yes, I sometimes despair when I see them. I try and improve my own teams, but it's it's a struggle.
Yeah, absolutely. Thank you. So that was that one. And then
I was going to comment on that last one. The KFRE was very high at 77, and that actually does take into account the fact that he would be dead before he got there, for example. So we quite often say to patients, yeah, your kidney function's low, but your kidneys are likely to outlive you. But in this guy's case, he's 77. There's a 30% chance that he is actually going to get on to dialysis, i.e. that he's not going to die of something else or be too unfit for dialysis. This is a risk of him requiring dialysis. So and if you give the SGLT2 and the ACE inhibitor and get the ACR down to 20, for example, and recalculate that KFRE, you may well get that down to 10%. So these medications will reduce the KFRE. So each time you add in an intervention and reduce the proteinuria, you can recalculate it. And what I've found quite helpful is when you actually put patients on medications and recalculate, you can actually show them how much we've reduced their risk.
Yeah, which can be really powerful, and that counters some of that negativity around sort of the sort of side effect side of things as well. It's sort of I guess sharing that positive so the
But it
patient's
shows
got
the importance
balanced.
as well of getting these medications in and up titrated early.
Absolutely. So our last case study it is quite an elderly lady. She is 82 with a raised KFRE, and again, hopefully it will become apparent why we have picked this patient. So really high UACR there, over 1,000, and that in itself would be a referral criteria in addition to that KFRE. But the real concern about this patient, and the reason that we picked it out, Georgina has picked up on this a little bit earlier, but this particular patient had not previously tolerated dapagliflozin going back quite a few years. And it was interesting that there was some concerns from the clinician at the time that they could try another SGLT2, and they recognised that SGLT2s would have benefit, but they were really concerned about it being contraindicated if the EGFR dropped below 30. And so it was really a real reminder and a highlighting of that. Those cutoffs for EGFR are for initiation, and they are slightly different for those 3 SGLT2s. So we put those on that slide there, 20, 25 and 30 for EMPA, DAPA and CANI. But you do not need to stop them. That's just for your cutoff for when you initiate them. You don't need to stop them if the EGFR drops below those. That's just for starting. And I know Georgina's kind of covered that before, but it is something we've seen a few times that people are worried about starting them because the EGFR is getting close to that, and they think, oh, well, there's no point because I'll have to stop it soon. And so it's just as a reminder that you don't need to.
Yeah, but also if you see some really big numbers for proteinuria, got to be thinking about myeloma. Diabetes is really common and it's most likely the cause here. But with a big number like that, she does need a myeloma screen and a referral just to check we're not missing anything. So we get lots of referrals when it's gone red and it's sort of 8 or 15, the ACR. We're not worried about those ones. We want them on the right treatment. But if you start getting into sort of the hundreds and there's not a clear cause, or that diabetes hasn't been proven as a cause, please get some advice and send them our way.
Okay, thank you. So we have come to the end. So we have hopefully covered everything that we set out to. We've talked about what CKD is and covered some of the classification, talked about that estimating of renal function and some of the financial and clinical implications to our patients. So a reminder that local data was from CVD Prevent. So if you're not familiar with it already, it's worth having a look at and seeing how you're doing, how your practice or PCN is doing compared to other people nearby. And we've talked a lot about sort of identifying those patients, more so in that previous session back in the autumn, but sort of touched upon it today, and then really covered that management. So hopefully you're going away from today feeling a lot more confident about monitoring frequency and about some of those management options for your patients, and some real clarity there, I think, as well on when to refer, and really big adverts for our local nephrology teams and how sort of supportive they are with their care. So hopefully that's been helpful. Are there any other questions that anybody would like to chip in? We have got 2 minutes left to keep on time for Mel.
I think there's lots of thank yous and saying it was a great presentation. So well done, ladies. I think there was lots of people as well outside of this, as well as in the chat, asking about slides. So I have said we'll look at that at a later date. I know you've got to edit them and things, and then we can send them out to people, but it won't be straight away.
Yeah, absolutely. And then obviously it's been recorded as well, so that can be shared to people afterwards. So
Actually, very briefly, it's not, it wasn't. There's actually a Midland CKD network, and there's lots of nephrologists on there. There's about 2 patients on there, and there's a very small handful of GPs and 1 renal pharmacist on there. But actually, there isn't that much involvement from the multidisciplinary teams. And the plan is that we try and get all of these sort of guidance and things rolled out across the whole Midlands. So rather than duplicating and doing it at each different, CCG or GP practice, whatever, to actually try and get guidance that's rolled out across the whole of the Midlands or the whole of the country. But there's lacking representation. So if anyone's interested in that, please let me know. You've got my email address in the chat already. But I can then sort of put you in contact with the team that are running that if anyone's got a sort of budding interest in getting involved in CKD management.
I
can't hear you,
something in the chat. Sorry, I was just, somebody's asked about the renal drug handbook and how useful that is in determining doses of medication. It is an absolutely invaluable resource because it's based on clinical experience of those drugs. So what you will find is that the drug companies will have contraindications or cautions for renal function if they excluded them from their trials, which is really unhelpful. Where clinical experience exists for the medication, it might have been outside the trial, but it might be commonly used in the patient cohort and good experience, and that will be reflected in the dose recommendations in the renal handbook. I would always defer to it. There's some really clever people that input into that. And it is all based on patient experience and use of those drugs in renal patients. So it's absolute Bible if you're doing your.
There's only one issue with that though, I suppose, which is that it's quite expensive. So if you've got the subscription, it's fantastic. If you haven't, there's lots of old PDF copies, but they're quite old now. So I just want to issue a bit of caution about the old ones. And the BNF does have a little bit more data in than before, but but once again, use us. We have a renal pharmacist who's happy to give advice. So if you've got a drug that you think someone should really be on, but BNF says no, please ask us for advice, because we will give that advice and we'll give the alternatives as well.
You can also all access primary, so secondary care although you can obviously do advice and guidance in secondary care commission to do that. If you want specific medicine information, you can access that via SPS medication. That's centralised, and that's how that service is commissioned, and they have access to the renal drug handbook and all of the other resources, and they can evaluate those and bits. So you wouldn't be able to ask the renal pharmacist directly. You would have to go via SPS, but they would use the same resources to provide you that dose adjustments information. And any pharmacists on the call that are members of RPS, you can access up-to-date renal handbooks via the RPS library. I appreciate that won't be relevant for everybody, but there may be people on the call who do have access to that and don't realise that resource is there. Okay.
I think that's the questions. I think that's all of them.
Good.
So far.
Once those nice flow sheets get ratified in the next couple of weeks and sent to you, that will essentially have all of the essential information from the entire talk. So if you felt you've been baffled by too much content, just wait for them to come out, and then once they're out,
2 weeks might be overly optimistic. I'm not sure the ICB likes that quickly. Just like to moderate the expectation, because that's beyond our control.
That's perfect. Thank you, ladies. I've put your email in there a couple of times, I think now, Georgina. So hopefully everybody's got that.
Brilliant. Thank you very much.
Perfect. Thank you. And thank you, Philippa. That's amazing, as always. Right then, so we've got a couple of minutes. I think I might just give people till 12:30 actually. I think Claire is on the call, but I have actually emailed her just to give everybody a quick 5 minutes in case you need to nip to the loo or grab a coffee. And I think we'll start at 12:30. That just gives us enough time for everybody just to stand up, walk about for a minute, because that was quite a great topic, but a heavy one. So we'll be back at 12:30. Welcome back, everyone. So we've now on to our final session of today's PLT. We've got an update on Northamptonshire's end-of-life care strategy and some guidance around the digital respect training. So I am going to hand you over. There's quite a lot of speakers, I believe, and I think you're all here. So we've got Claire Mansfield, we've got Naomi Coldwell, we have got Katie, where are you? Di Stefano. I might have said that wrong. Apologies to you, Katie, and Laura Clifford. So I will hand you over now. I will manage the chat throughout if anybody's got any questions.
Thank you very much. I think I'm going to start. So hello, everybody. Good afternoon. My name's Naomi Caldwell. I'm a GP in Northampton. I'm also leading the palliative and end-of-life care programme at the ICB, and I am Deputy Chief Medical Officer for the ICB. Palliative and end-of-life care has always been a passion of mine in general practice, but I've also worked at both Cynthia Spencer and Cransley Hospice as a clinical assistant and a specialty doctor, and then have gone on to be a Macmillan GP also. So we've come today, there's the group of us, and I'll allow everybody to introduce themselves shortly, just to talk to you a little bit about the palliative and end-of-life care strategy, where we are with it, what we've achieved so far, and what our plans for the future are. In addition to that, we'll also be talking through the implementation of the electronic respect form, which is now implemented across the system and is accessed through the NCR or Northamptonshire Care Record. So we have digital colleagues who will be able to talk us through that as well. If you've got any questions, then please put them in the chat, and I'll try and answer as we go along, or we can come back to them at the end. But I hope that you find the next session informative, and thank you very much for attending. So I'm going to hand over to my colleagues just so that they can introduce themselves briefly, and then we'll make a start. Claire, did you want to introduce yourself?
Good afternoon, everybody. My name is Claire Mansfield. I'm the Macmillan Palliative and End-of-Life Care Transformational Leader with Northamptonshire ICB.
Thank you, Claire. Katie?
Hello, I'm Katie Di Stefano, and I'm the Project Manager for the Northamptonshire Care Record.
Thank you, Katie. And Laura?
Hi everyone, my name's Laura Clifford, so I'm the Palliative and End-of-Life Care Commissioning Manager at Northamptonshire ICB.
Thank you. So I'm going to hand over to, I think it's Claire, who's going to talk us through a presentation. Thank you, Claire. I think you're on mute, Claire.
Apologies. Can everyone see the presentation now?
Yeah.
Yeah.
Yeah. Lovely. Thank you. So thank you, everybody, and thanks for the introductions, Naomi. So this is to give you a palliative and end-of-life care overview for the system, and then we'll move on to talking about respect, as Naomi has said. So just to introduce the Northamptonshire All-Age Last Years of Life strategy from 2023 to 2026. Some of you may well be aware of this. It's based around the ambitions for palliative and end-of-life care, which is a national framework. We're really lucky within palliative and end-of-life care that we have this framework, which is nationally agreed. There's a significant buy-in to this with these 6 key ambition areas that cover everything that we want to achieve going forward to give a really holistic approach to palliative and end-of-life care. Within the strategy, we've got some clearly set out actions now, supported by task and finish groups, to make sure that we look at both availability and accessibility of our services right across the system. The plan is that this enables us to ensure that individuals nearing the end of their life receive that high quality, compassionate care that we all want to deliver, and people are supported to live and die well with dignity in a place of their choosing. Just to talk a little bit about my role now. So I came into post in June 2024. Several systems across the country have Macmillan Palliative and End of Life Care Transformational Leader. I've just listed those systems there. So we work very closely with our Midlands colleagues, but we also link all around the country and into Wales and Northern Ireland as well, sharing initiatives, sharing practice and looking to move forward together. It's an all-age approach, so we work with children and young people's teams as well, our care homes, community and acute providers, including primary care, engage with all of our stakeholders, look at public and user involvement and equality of access as well. So we're linking into lots of our community groups, core 20+5 communities as well. So just to share some of what we've achieved so far within this programme, lots of links have been established with user groups, religious cultural groups, patient collaboratives, dementia work streams, LDA colleagues. We're really trying to link into every forum possible. But if you do have forums that you link in with that you feel would be helpful for us, we're really happy to hear from you. And our contact details are at the end of the presentation. We were under NHS England programme reviews that were a level 2 monitoring, so it was very regularly that we had to submit information. Given the information submitted in the past, that's now moved from a quarterly to a level 2, a sort of annual monitoring process. As part of our urgent and emergency care work stream, there's been recruitment to a specialist palliative care nurse who's available on Fridays, Saturdays and Sundays, sitting within the ICT team and taking direct referrals from there, but also from partners all across the community. So that's a really helpful post to us to look at that demand on Fridays, Saturdays and Sundays for a palliative care role and hope to build on that in future. Our hospice charity colleagues have recently funded a phase 1 bereavement project that would commence early 2025. So we hope by April that will be off the ground and we will let you know information around that. That is limited to people who have been looked after by palliative and end of life care services in the county. But it is a resource that we can use for those patients that's lacking at the moment. Digital Respect, as you may be aware, is now live on the Northamptonshire Care Record. We have an active Respect Champions group attended by multiple stakeholders, always happy to welcome colleagues from primary care. So if you're interested in that, please also let us know. And there has been some Respect delegated authority training completed by specialist palliative care CNS teams. I'm aware that there's interest within our nursing colleagues within primary care, and some people are completing these roles at the moment. Really happy to discuss with anyone that role going forward and how that might work and be supported. Other achievements, there's now a countywide palliative and end-of-life care information platform hosted on our hospice websites. Details of those are at the end. They're very user-friendly. Our Autism Champions group are reviewing those at the moment to make sure that they're as accessible as possible as well. We are working on a competitive procurement process for the new countywide community-based specialist level palliative and end-of-life care service for adults. So that would be a service that commenced in 2026 and is the service that's currently provided by Marie Curie at the moment. So it's not a new service, but it's a recommissioning of that existing provision. We've talked about my post coming in. And then we have some public awareness events planned. So please look out in the comms that comes out from around primary care, and certainly Mel, we can let you know about these events. Dying Matters Week in May 2025. We're going to be in 4 locations around the county, looking to have some public engagement events. And our Hindu colleagues in Wellingborough are holding a multicultural health and wellbeing Mela. We can also send some details of that round for colleagues in that area that might be interested and attended. There's been quite a lot of buy-in from local groups attending that event. We're also, from an all-age point of view, looking at CYP transition events. So we have up to 22 children and young people in this county that will start to move through to our adult palliative and end-of-life care services. And it's about ensuring we manage that transition appropriately for them. And we're also making enhanced links with our border areas. We're well aware that we have several borders in Northamptonshire, and it's about how we work appropriately and effectively with them. So we've covered the great work that's been happening. However, we do have a lot of challenges with within our system, and I'm sure some of you can relate to these. So our non-malignant conditions, there's support out there for malignant patients. I'm not saying it's perfect, but there is a lot more resource sometimes for a malignant patient. So our non-malignant, non-cancerous conditions, there's limited support. Our 24/7 access is very limited to those patients already known within a palliative and end-of-life care system. So that would be to our Marie Curie colleagues at the moment. We don't have 24/7 hospice access, and there isn't any phone line 24/7 for members of the public to be ringing. Within children and young people, we don't have our own children's hospice, so it's around that transitional care model that we've been speaking about before, and looking at future funding to ensure there is 24/7 cover for any child in the county that would want to die at home. Our available data isn't used well at the moment, so digitally we need to look at what we've got available and use that to inform and support our services going forward. We also need to move forward with something called EPACS, which is an electronic palliative care coordination system that would be a shared system across all providers, so everybody could see the same information and would work in a similar way to the new digital Respect, where all providers are able to see that form in a live version. There's, as you'll be aware, reduced funding availability across the whole sector. Previous grants that we used to receive are no longer available, so we're very limited in where we can source funding. We need to look at our inequalities, ensuring there's equitable access, appropriate ability to communicate, that cultural competence across all of our workforce, and looking at how we're supporting all of our communities. We need to look at the wellbeing needs, including bereavement of our patients, those important to them, and also our staff. That fits into the workforce and training, ensuring available training is there for all, but also looking at how we train and support members of the public to support us. And finally, our user involvement, that's quite limited. We are aware that palliative and end-of-life care is a challenging area. There will be a public questionnaire going out soon, and as part of that, members of the public will be able to offer their support, and that might be a one-off conversation. It might be becoming part of a user group going forward. So the solution to these challenges and how we're looking to move forward from a palliative and end-of-life care point of view across the system is to co-produce a collaborative programme, and we're bringing some key partners together in March to try and take this forward, so that we've got a very clear defined governance structure. We've got the right people in the right room at the right time, able to make those decisions about finance, funding and commissioning, and take this forward as a system, ensuring that there is equity by design and user focus involvement within that as well. We know we need to link closer with urgent and emergency care work streams, and utilise our existing stakeholder engagement. So we have some really good operational and clinical support forums across the system, and we really need to pull in the work that's coming from those. In addition to that, so we'll be talking about the Northamptonshire Care Record today. This is the first shared digital platform available across the system, and Katie will be talking about some of the benefits of that, particularly for primary care. We're looking at how we can support registered nurses in nursing homes to verify death, development of a self or lay carer medication administration policy, and that would be for people with a known long-term life-limiting condition or at the end of life. Partnership working across the system to support our patients living in those border areas. Again, we're very conscious we have many border areas and there's lots of different arrangements, so trying to gain some clarity in those areas for our colleagues, and then the co-production of the collaborative programme, which we talked about. One other thing to just make you all aware of, very relevant in primary care, there will be a future simplified version of the special patient note for palliative care patients. That's just being looked at the moment. We're conscious the special patient note as it stands has lots of different boxes that sometimes it's difficult for people to know what to fill in where. This would be quite specific for palliative care, but hopefully clearer and easier, and take less time to complete. So please look out for that coming forward. And again, we'll send all the appropriate comms round in relation to that. Colleagues have previously asked, and we will, these slides will be able to come out with you. We're very happy to share them just for some information about support available within the last weeks of life. So all of those services are here with the links in. It's worth noting as well, Northamptonshire carers will support a family for up to a year after death. So please bear that in mind if you're thinking a referral might not be relevant because someone is very poorly and likely to die very soon. That referral can go in, and that support can be there for up to a year. I'm going to come on now to talk about respect. Was there anything particular, Mel, in the chat from that we want to talk about now? No, so I carry on.
Yeah, I think there's just a couple of things about NCR, but Katie will probably be able to pick those up in her
Lovely.
presentation. But yeah, no, thank you, Claire. Please carry on.
Okay, fab. So respect. So respect, as you'll be aware, is a recommended summary plan for emergency care and treatment. It's the personalised recommendations for a person's clinical care and treatment in the case of a future emergency, where something happened and they weren't able to make choices or express their wishes at that time. So that might be because they're unconscious or they're unable to talk to us or tell us what they would like, or they don't have capacity to do that at that time. And these recommendations are created through conversations with the person, with their family, those important to them, their healthcare professionals, and anyone else that's key in that person's life, so that we can ensure we understand what matters to that person and what's realistic also in terms of their care and treatment. So their patient preferences and clinical recommendations would be discussed and then recorded. It's a non-legally binding plan, and it can be reviewed at any time when circumstances change. And with it being a live document on the NCR, it's very helpful that change can be uploaded immediately and is available then immediately to system partners, because it's a live document. So respect is for anyone at all can have a respect form. We know it's increasingly used for those with complex health needs, people likely to be nearing the end of their lives, and people at risk of a sudden deterioration or cardiac arrest. So respect is available as a live document on the NCR at the moment for all patients within Northamptonshire. And just in relation to some of the queries we've had, so it does replace the DNA CPR form. However, there is no expectation that patients with an existing DNA CPR form have to have that recompleted. Those DNA CPR forms remain valid within the system. If the patient goes to hospital with a paper DNA CPR, that is still recognised. And the DNA CPR policy in the system is active until the 31st of October 2025. We've had some care homes have contacted us saying, goodness, do we need to do a respect form for all of our patients? And we've been very clear and fed back that no, if that DNA CPR is in place, that remains in place, but at an appropriate opportunity or if something changes, that could change to a respect form. However, if a new patient came into that care home, that would be the ideal opportunity if they didn't have an existing DNA CPR, that a respect form would be completed at that time. Someone having a respect plan in place doesn't necessarily mean they have a DNA CPR decision, so it's always worth double checking that. But often in the palliative and end of life care caseload, there would be a DNA CPR decision as part of that form. Plans are completed and stored digitally via the Northamptonshire Care Record, which Katie will talk about, but they should be coded in the local system. But the document is completed in the NCR, because by it sitting on the NCR, that's where everyone can see it shared across the system. There's just some additional resources there for everyone. They're quite useful, and the link to the respect resources on the Resus Council UK. I won't go through them, but you can access those as you wish. Just some hints and tips that have come up from us talking with clinicians who are completing the form. So using the person's own words where appropriate is really helpful and very powerful in supporting their needs and wishes. Being aware that the plan will be considered in both acute and community settings, so documenting appropriately that so for example, ward-based care would not be an appropriate thing to write in either setting, and we want to move away from things like that. And we know that there's been issues in other systems with documentation like that, so it's having that broader awareness. Colleagues in acute care and community settings will look at these forms. They must be completed by an authorised clinician, so within primary care that would usually be a GP or a delegated authority nurse from a practice where that has been agreed within that practice and appropriate training undertaken. Key points are really helpful and really clear to the reader in an urgent situation. Also key to think about what information you'd like to know at 3 o'clock in the morning, because that's actually when things might happen or change. And actually, as the clinician supporting that person, what would you want to know at 3 o'clock to be able to support them best, direct them to the right place, make the right ongoing referral? And the plan can be completed following one or more conversations. So this doesn't have to be an all at once conversation. So just to bear that in mind, because we do appreciate that talking about this can be difficult, and it can take a few conversations with a patient and then with their family to have these discussions. This is just where you would find Respect on the Northamptonshire Care Record landing page. I'm going to hand you over now to Katie, who's going to talk more about the NCR and Respect within the NCR. Thank you.
Great, thank you, Claire. So hi everyone. So as I mentioned, I'm the project manager for the Northamptonshire Care Record. So what I'm going to do, just give you a sort of a brief overview of NCR, what it is and how it operates, and then I can jump in and just quickly walk you through the way Respect sits in effect on the screen. So the NCR has been live across the county since October 23. And it's a system that brings together a range of data from GP practices, both System 1 and EMIS practices, Kettering General Hospital, Northampton General Hospital, and community and mental health. As I'm sure you understand, with the nature of data, there's an element of we bring in the data that we can bring in. Again, as I'm sure you know, within the acutes, there's a range of systems that they have. Some are more digitally enabled than others, which means that some are easier to get data out of. So we have in NCR at the moment what we can get. We're working on expanding the data that is available for everybody to view. We're also looking at, well, as additional data sources such as adult social care, children's social care. We're also looking at out of hours and 111 service as well. So it's a growing platform in terms of the data. But as Claire's already mentioned, the main purpose of the system is providing information. So when you're treating a patient or an individual in relation to their direct care, it's giving you perhaps more information on that individual than you would previously have had just by looking at your own system. So in a GP environment, you would be able to see, for example, hospital activity, and you could see if they've been into an acute, or you know, just as an outpatient or what have you, or if they have any upcoming appointments, if they're with you and they say, oh, I'm sure I must have an appointment coming up soon, you can actually go into NCR and you can see when that appointment is and just give them the reassurance that yes, it's next week, 2 o'clock on Thursday or something like that. The system is available to all GP practices across the county, and if you are in an EMIS practice, I have got some screenshots of how to get to it, but ultimately you, I believe, expand the left-hand side of the screen, you have access to the GraphNet portal. GraphNet is the supplier that the platform sits on. And then if you are accessing via System 1, there should be a small blue tealy coloured button within your toolbar, and that's how you launch the NCR. So it's launched in context. So the patient record that you are viewing within EMIS or System 1, you click the button or the link accordingly, and it takes you straight into that patient record in NCR. You don't have to go into NCR and try and find a patient. It will just open it up in context. Claire's shown you the landing screen. What I'm going to do is I'm going to jump onto my screen. Typically, my usual test patient isn't available, so I'm going to have to use a different one. But again, this is a test patient, so there's no live data here at all. But imagine if I've just gone from System 1 or EMIS, clicked the button or the link. This is the screen that I have in front of me. Just to point out, we do have two access levels. This is the clinical access level, which gives you a range of tiles across the top. And we also have an administrative level as well, and that just has a slightly reduced amount of information. But that is all driven by, in effect, smart card access. So whatever access you have within the practice will be the access that you have within NCR. But talking about respect specifically, we have the blue tile top left of the screen for respect. So again, this is the test patient. I'm just going to go into here. And this follows what Claire said, that you would have coded your record and done all the appropriate tasks that you would do in your current system. But then instead of creating, in effect, and filling in the purple form in, for example, system 1, you're now filling in the purple form on this system here. So this test patient doesn't have a form at the moment. If you have clinical access rights and authorization, i.e. you've done the training, or you are the relevant person, appropriate person to create a form, quite simply, we have a create button, and that then just brings up that purple form in front of you. It's an exact copy of the Resource Council form, of the paper form, or of a form that you may have seen in other platforms. It is exactly the same. There's no deviation from it at all. And again, we just have this reminder in the system that should only be completed by those authorised to do so. The fields here are mandatory, so they're marked with a red asterisk for you to fill in. Again, it just allows for making sure that the form that is completed, in effect, has the most comprehensive information that you can put in, again, for the benefit of everybody else who would be viewing that form. It is a 2-page document. You can scroll down, and then you can simply at the bottom just go to your second page. Again, it's just like turning over the piece of paper. And then when you've completed the form and you have done the put in the relevant information, a digital signature is required here, and the digital signature is acceptable and it is appropriate to do so. At the top of the screen, you can just save the form. Once that form is saved, it is automatically published to the NCR, in effect, immediately. So that record is there then available for others who use the system. So as I've mentioned, GPs, acutes, NHFT currently who have access to the system can view that form in real time. And then once the form has been published, anybody who has, again, the clinical rights has the ability to edit that form as well. And again, I know Claire mentioned this, but it just means that those edits can be kept on the one form, and the system is fully auditable in that there's a revision history. So perhaps previously, where a form may have been updated, you strike through the form, perhaps put it at the back of a record, or it gets shredded and removed from a record. You can actually see previous versions, so you could see what it perhaps said 6 weeks ago, or what have you. There is also, once it is saved, there's the option to print from this screen as well. Local policy states that a patient should always have a hard copy of the form anyway, regardless of the mechanism or the method in which the form is created. So you can print a form directly from NCR to give a copy to the patient. It's a very simple demo, really. It's pretty obvious in terms of, like I say, where we would go with respect. It's just the top left-hand button. And if a patient does have a respect form in place, we just have then a new line entry across this system which would say respect form, and you can then, that's the tell that there is already one in place. But again, you can access the information just by clicking respect at the top left-hand side of the screen. That's pretty much in a nutshell, NCR, how that and how respect operates within the system. But I am more than happy to take either any NCR questions now or separately. I've been doing a lot of work with GP practices. If you want me to have sort of to do demos across the practice in terms more from an NCR point of view, more than happy to do that, or get in the car and come and see you. So happy to assist and get in the NCR access embedded, I think, into process. Naomi, you use NCR. I mean, I don't know if you just wanted to, I was just looking there, if you wanted to have any comments about it.
Yeah, I do use NCR. I think there's some talk about people, how they find it on EMIS. So I think if people have got specific questions, it might be worth contacting Katie directly. I only know how to access it on System 1, but I know that we have a link in It's actually really useful just if you see a patient and they say, oh yeah, I think I've got a gynecology appointment, I think it's next month, I'm not really sure. You can click on that and it will tell you the date and time and the consultant that they're booked to see. So it does actually save admin teams quite a lot of time chasing up appointments. So for that reason, even alone, it's very worthwhile. In terms of the respect form, because it's accessible, as Katie said, not by everybody, so care homes don't have access to it at the moment, but you know, NGH, KGH, NHFT do. So if you fill out a form, or one of your GPs fills out a form for that patient and they then present in the ED department, the ED department have on their protocol that they will always check for a respect form. So they will look to see if a patient has a respect form and what is written on it. Now that NGH and KGH are live with respect, also read write access, it works the other way. So if you have a patient where a form has been completed elsewhere, whether that's in NGH, KGH, possibly the palliative care team within NHFT, maybe within the hospice, then at the point that that form is completed within a GP surgery, you will be able to log on to NCR and see that form live, which again is really helpful. So if those conversations are happening elsewhere and being documented on a respect form, then we will be able to see the information that's been put on there, and sometimes it can encourage a further conversation, or it stops having to repeat the same conversation. There's a few questions in the chat. So if you have delegated authority and you have been completing a DNA CPR form, then you need to have that delegated authority to complete the respect form, and that is something for your individual practices to assess whether you have the competencies to do that. So absolutely, you can only sign the respect form if you have had the relevant training and your surgery are happy for you to complete those respect forms. That's not to say that not everybody shouldn't be aware that they exist, and that includes, down to reception staff and all sorts of people. And part of this awareness, so we're going to take this to the GP PLT hopefully next month, is to say, just please check for it, because it often holds a lot of information and stops the patient having to. We hear about patients saying, I don't want to have to tell my story several times. This is one way of documenting that information. I'm going to have a quick look at the chat to see if there's anything else. Can
I jump in, Naomi, if you don't mind?
Of course you can. Yeah.
So, Sophiella, hi. I will send you the documentation for EMIS, and that's got the how-to guide of how to access NCR. But I am actually coming over to see you in a few weeks as well, so I can also take any questions then. But I'll get the guide over to you. No problem at all.
I can see someone's put a question about filling out the respect form, but not on System 1. Yes, please fill it out on the NCR, not within your System 1. If you fill it out within System 1, it is only you or those people who have access to your system that can see it. If you fill it out on the NCR, then all those people who have access to the NCR can see it. It doesn't need to be saved back into the patient record. CQC have clarified that, so it can be completed on NCR, saved on NCR, a copy printed and given to the patient, so that if anybody turns up in that patient's home, the patient then has the ability to consent to give somebody the form to have a look at, because we know not all providers have access to this. You can still fill it out on System 1, but we would encourage you please to do it on NCR, so that we have that system-wide working. There's a bit about training in the community for people, so again that's something that we can pick up if you need specific training. If you get in contact with us, then we can look at what training is available. There has already been some delegated authority training, and there's more that will be planned for the future. What else has someone put? How do you get the rights to complete them on NCR? Is it person specific? So like Katie said, it's based on your smart card access, the level of access that you will get. You do need to have had that training to complete it, and you also need the sign off from your GP partnership that you have that delegated authority to do so. Within other settings like NGH, KGH, NHFT, there are different processes to ensure that it's only those clinicians who have delegated authority who are completing these forms. Someone's put, when a patient comes out of hospital and a respect form has been issued, does the surgery need to then review the respect form again? No, you don't need to review the respect form if someone has had that conversation and it has been documented. It is useful for you to know that it's there. It's incredibly useful to code it, so please use the codes. We all have access to Arden's templates, and within Arden's template there is a code that you can use to say that a respect form exists. It may be that if the situation changes for the patient, that another conversation is had, and at that point you can update the form if there's things that have changed. When you publish it again, that new form will be live. There will be an audit trail, so you will know that it has been changed in the past. Again, please give the patient a hard copy of it and ensure that they destroy any previous hard copies. Someone said we use EMIS at St Andrews, but not sure whether we will have access to this as we're not a registered GP surgery. I think I'll come back to Katie. I think that's another provider on the list who have to go through the process in order to access NCR, of which I think we have several. But